Hello, and welcome to Co-occurring Mental Health Disorders and Intellectual Disabilities, a guide to diagnosis and treatment. Let me go ahead and share my screen with you, and we could get started. Okay, there we go. All right, well, let's talk about the first order of business, and I'll tell you a little bit about myself. I'm Jeff Kupfer. I'm one of the presenters in this course. I'm a licensed psychologist and board certified behavior analyst practicing in Colorado. Thank you for joining us for this session. I received my PhD in psychology from the University of Florida in an area called the experimental analysis behavior, conducting research in animal models of learning. But then opportunity knocked. I completed all of my licensing, supervision, dissertation research, and postdoc training in Boston in the 80s and 90s. It was a great time to be in Boston during this period. It was a time in which state schools and state hospitals were closing for deinstitutionalization and returning to community settings. It was a time in which psychotropic medications dominated the treatment for persons with developmental disabilities and mental illness. In fact, it got so bad that the state of Massachusetts put forth a plan for judges to conduct substituted judgment to persons receiving psychotropic medication who lacked the capacity to make informed decisions. At the same time, traumatic brain injury rehabilitation was getting off the ground, something called neurobehavior. This became my primary focus for over 2 decades. Of course, the other place that brain injury rehabilitation took off was in Denver, in the Denver area, and at Craig Hospital. So I moved out west and landed in Colorado. Currently, I'm a lecturer at the University of Colorado in Denver, clinical director of Oliver Behavioral Consultants, and the board certified and behavior analyst, as well as on the board of trustees for the Cambridge Center for Behavioral Studies. I work with all ages, from early intervention to dementia-related disorders. Finally, I enjoy running, biking, cooking, piano, and generally holding down the fort while my wife attends medical school. We have 2 dogs, Violet and Bosco, our rescue pups, and we try each day to live up to their expectations. That's a little bit about me. Let's go ahead and get started. I want to note something, make sure that everybody understands some of the parameters of the material we're going to cover. So I'm just going to read this to you very briefly. This manual is intended for use by qualified professionals and is based upon the current best clinical practice and on DSM-5 and DMID-2. The categories included in this text are not exhaustive of all conditions for which people with IDD may be treated. Diagnostic criteria and treatment approaches contained in this text are included to improve diagnosis and treatment in persons with IDD so that they may have improved access to services. These criteria may not be relevant to legal issues such as competency. Okay. And now I want to just mention something about some of the language that we will be using. In graduate school, I had the opportunity to read a book, very important book, the writings of Benjamin Whorf, and the book is called Language, Thought, and Reality. And in this book, there was a lot of great stuff in there, but this is one of the quotes that I think is very, very important. He said that language determines a person's perception. That is, the way one talks about the world affects all one's responses and categories of stimuli that control these responses. I'm going to be referencing this throughout this course, and in particular today, because we're going to be talking about topics and the way we actually perceive perception and the way we perceive things such as private events and self-description sorts of skills. How do we come to learn to talk about what's going on, so-called inside of us, inside our heads? And more importantly, how do we figure out what's going on in the heads of others, so to speak, relative to mental health and ID? So when we're talking about the language, I want to point out that the way we talk about people and things change. They have changed over the years, certainly since I've gotten into the field, and they will continue to change. Similarly, the way we conceptualize and provide treatment will change in accordance with the way we come to learn to talk about and understand uh, persons with mental health issues and intellectual disabilities. Much of this is driven by evidence-based research. We will reference this as much as possible when we are discussing some of these diagnoses and treatments. And again, in this course, we're going to not just talk about what's going on right now in the present. We're going to talk about the past, like in about a second. And we're also going to talk about projecting of what might happen or what could be in the future in terms of how we come to treat and understand mental illness. Two of the books that were instrumental in our putting the material together. One is the DMID2, and this is by Fletcher, Barnhill, and Cooper. And then the second book was a book that was edited by Johnny Matson, The Handbook of Intellectual Disabilities. Both of these books are available. You can get them online. I highly recommend them. And I'd like to start now with the introduction to assessment, because what we're going to be talking about in this particular lecture today is the process of assessment. It's always the starting point. And I want to, again, go back to the past, the way things used to be when I first entered the field. That's going to be the scope. We're looking probably at early 1980s all the way to present. That's the range of time that we're going to be talking about. I had the opportunity in Boston to work alongside of a brilliant woman. Her name was Anne Hurley. And I got an opportunity to see Anne really, really shine in working with persons with developmental disabilities, but more importantly, bridging a gap of mental illness and developmental disabilities. And she did this with a person named Bob Sovner. The two of them developed a reading that was pretty popular back in the 80s. Psychiatric Aspects of Mental Retardation, I think, was the title of that. And one of the things that they noted in some of their early papers, Sovner and Hurley, was that many primary psychiatric disorders are also neurodevelopmental in nature. They went on to describe that the risk for early onset of psychiatric disorders is influenced by four things relative to neurodevelopmental nature. Number one, genes and environment interactions. Not just genes, not just environment, but the genes and the environments actually interact. The second was the timing of the early developmental stressors or early trauma. If those were early on, what ages was that happening? And we're going to cover trauma informed treatment and trauma related disorders in one of our later lectures. The third area was the history of learning experiences. What does the person is exposed to throughout their lives? What they learn from their parents, their caregivers, their siblings, teachers in schools, all the influences that may go on in terms of spiritual, all of those things become part of the learning experience. Basically, a lot of the social learning. And then finally, the presence of a specific behavioral phenotype. What might that be? So these are the four areas that Sovner and Hurley identified as risks for early onset for psychiatric disorders, intellectual disabilities, and or autism spectrum disorders. They will alter the development, assessment, and treatment of several psychiatric disorders. The severity of intellectual disability and ASD plays a role in the development of challenging behaviors such as aggression, self-injurious behavior, and general disruption. In that same paper, um, the authors identify cases meeting diagnostic criteria for affective disorders at all levels of intellectual disabilities. They found that for severe and profound intellectual disabilities, behavioral changes and vegetative symptoms were signals for affective disorders. For higher functioning ID, individuals rarely verbalized problems, but appeared to be sullen and apathetic or had delusions of guilt or persecution. And then finally, for patients with elated mood, they did not present with grandiosity, but might actually present with much more aggression. One of the things that we'll be talking about is what exactly happens that triggers a person to go in for an assessment in the first place. What are some of the behavioral features or symptoms that will present themselves upon access to somebody who's going to perform an initial assessment to determine what the underlying problems may be? Sovner in 86 went on to describe 4 difficulties in assessing persons with intellectual disabilities. The first one is what he called baseline exaggeration. Here we see an increase in challenging behavior, frequency, and or intensity during the course of mental illness. The second is intellectual distortion. Individual cannot accurately understand questions posed by the evaluator nor assemble the correct information to respond. The third is psychosocial masking. Due to developmental delay, the individual might present significant symptoms that occur within a developmental framework and would be common in a young child. Okay, and then finally, cognitive disintegration, in which the individual may become grossly disorganized and psychotic due to lack of cognitive reserve to cope with their illness. Again, these are 4 areas that become difficult when we're assessing persons with ID. Some assessment challenges are that the aim of assessment and diagnosis in general is to move in a direction toward discussing and developing treatment. We're going to talk more extensively about this particular process. Why do we do all this? We bring all this information together, but what do we hope to gather when we're doing all of this information? What is the ultimate aim in what we do, particularly in something like a course like we're taking right now? Well, we want to point out that there are 5 real challenges in addition to the ones that Sovner pointed out. First of all, and we're going to see this quite often as we go through this material, there are limits to psychiatric diagnostic interviews, self-report, historical accuracy and reliability, and introspection in general. The second challenge is that there's oftentimes the use of multiple sources of information. Sometimes that helps, but it may not be accurate or informed data. We're going to talk about that as well as the one just above this about the problem with introspection in general. A lot of times we use rating scales and symptom tracking. That's what we're really left with, but how much of that rating scale can be understood by somebody who has a moderate to severe intellectual disability? It may be hard to follow. We've worked in a variety of ways with persons who have difficulty, for example, just communicating, being able to speak. And this is happening from perhaps a traumatic brain injury. And sometimes those rating skills have to be modified so that we can get the information about the symptoms so that we can track it accurately. Psychosocial stressors and medical conditions also are challenges to many diagnostic processes. And then finally, some symptoms are just easier to discuss than others. When you clear all these other four out of the way, some of the symptoms are easier to discuss than others. And there are reasons why we could discuss some of these things easier than other things. All right, let's move on. Let's talk a little bit about interviews and the paradox that we see with the interview process. For persons with more severe intellectual disabilities, communication issues are more obvious. But for borderline mild ID, the language may appear perfectly fine, but mask problems with abstract concepts. Okay. This is something that we'll be talking about when we talk about depression and when we talk about anxiety and some of the ideas around what we talk about temporally talking about things in the past, in the present, and in the future. That temporal control may be very difficult for somebody to actually do. So some of the concepts that we'll be talking about are things such as the concept called worry. How does that relate in anxiety? Worry implies that we're talking about something in the future. But if a person does not have very good temporal discrimination skills, it may be difficult to get some of that information, even though they are verbally able to talk and be able to respond to some of the things that you're asking. That's what we mean by it may mask major problems with more abstract concepts. For example, an individual may reply no to the question, being anxious. Are you anxious? No, I'm not. But then turn around and say that they are describing, and it turns out to be a panic attack symptom that they're describing, but they don't necessarily describe this as anxious. It has not been connected in terms of that particular term to those particular bodily sensations that he's talking about or she's talking about with a panic attack. An individual also may not be able to differentiate hearing voices in their head from self-talk. One of the things that we will need to emphasize here is that we need to use language that is understandable, and we need to be able to verify comprehension. Two very important things that we try to do when we're doing the assessment process, particularly the interview process. Here are some recommendations that we could make on the interview process. First of all, as I mentioned, use very simple vocabulary words. Create short sentences. Ask one simple question at a time. Very important, wait for an answer. A lot of times as you're asking questions, you may feel rushed because you have to do this assessment and you have a timeline to get all the information done. But for somebody with an intellectual disability, it may take a little bit longer to process that particular question. You want to confirm that the individual understood the question. Use visuals, props, and gestures. Permit more time for an interview if necessary. Avoid leading questions, such as the one we just asked before and this one. Are you feeling depressed? Are you feeling anxious? That leads to yes, no. And you don't want to necessarily use yes, no kinds of questions. A person's history of compliance and obedience may also influence their willingness to answer questions. And are they going to be compliant with the questions that you ask, or are they going to be resistant and very guarded? That's a possibility too on some of the things that you're trying to get to gather information for a proper diagnosis. Let's talk briefly about the presenting problem and chief complaint. Okay. This is what we always do when we're starting out. We want to find out, we sit down with the person or their caregiver and ask them, why are you here? What could we do to help you? The presenting problem is usually part of other changes in functioning. Amongst the things we want to do are look for other sources of information regarding the onset and changes to obtain history. We want to find out how long has the problem been occurring, in what settings, if ongoing, and what has changed that makes this different than it was before. These become ways in which we gather information, and it's important information. For example, how long has the problem been occurring? When we start talking about diagnosis in the upcoming lectures, we're going to find out that the DSM-5 is pretty explicit about what those time parameters are. How long has it been occurring? More than 2 weeks, less than a month, um, more than 6 months, 3 months or longer, 1 year. All of those things become markers for differential diagnosis. In other words, what we're really trying to find out here is what's the reason for the referral? So amongst the things we want to oftentimes do are consider what we call psychosocial stressors and triggers. What are the things that brought the person to this particular state that they're in right now that they need to have an assessment performed? It could be the loss of a parent, loss of siblings, loss of pet is a big one. I've run into so many times in which I've done assessments, and this has been a big part of the problem. Pets are very important to families and to individuals as well. Transition to a new classroom, a disruption at home. If they're in a residential program, staff turnover, decrease in family contact, which happens so many times when a person goes into some sort of rehabilitation setting or into a residential program of one sort or another. Anniversary of a death, change in placement or family. All of these things can create psychosocial stressors that which can categorize in some sense to something that we'll talk about later on called reactive attachment disorder. You could see that particular disorder develop in persons who have had multiple foster care placements that have just not gone very well, or they've been very, very short in their duration. Consider medical problems such as gender disorders, TBI, digestive issues, dental pain, seizure disorders, and drug interactions. All of these things are questions that you're going to want to ask about as you're doing your assessment to gather information. There may be challenging behaviors, and which is oftentimes one of the reasons why persons are brought in for an assessment. The behavior has reached a point, a magnitude, in which it now needs to be professionally addressed. The challenging behaviors are oftentimes culturally abnormal behaviors that are maintained at a high rate, duration, or intensity that oftentimes places the individual or other persons at risk. Or it interferes with ability for a person to access community or facilities. A lot of times you'll see the DSM-5 describe various kinds of occupational, social, or vocational issues that come up, which are interfered with from the challenging of the behavior. These are some examples: aggression to self or others, which is a very primary concern that we immediately address when they come in for an assessment. Property destruction, stereotypic behaviors, and what we're talking about here might be what we call collateral responses. I'll talk about those later, that there may be various reasons why you see some stereotypic behaviors and what they may be indicative of. Disruption, intrusiveness, pica, which is eating in inedible objects, swallowing objects, rumination, which is essentially swallowing food and bringing it up over and over and over again, rumination behavior. And then finally, social contact. Okay, these are 7 various areas, challenging behaviors that could actually happen. In looking at prevalence as a general overview, we find that when it comes to some of these challenging behaviors I've just described, in the general population, 15 to 18% is oftentimes seen where we see challenging behaviors. But when we see these challenging behaviors in profound ID population, it's certainly higher. It's not 15 to 18%, it's more like 42 to 82%. That's a wide range. But the thing that is important to understand here is generally speaking, as a person with severity of intellectual disability is more and more severe, there's a positive correlation with challenging behaviors. The diagnosis and the developmental perspective is important to understand as well. We have to understand the tantrums of a 3-year-old versus a tantrum of a 35-year-old and how that may be, again, the developmental phase that the person is at, what it appears like when you see the tantrum. Next, is the problem location specific, or is it generalized to all settings? This is one of the first things I'll ask. Does this happen in the morning, afternoon, evening? And where does it happen most often? At home, at school, in the community? Where's the problem actually happening? Medical factors become extremely important. We're going to spend time talking about this throughout the course. Are the behaviors indicative of some type of physical distress? One of the big ones I've seen over the years is constipation. I've seen some pretty severe self-injurious behaviors directed at the head and at the stomach. And it turns out that the individual that we were working with had some severe either constipation or migraine headaches. Okay, so this is one of the things that we see as an indicator. It could also be a social problem, a repetitive stereotypic movement that could actually be indicative of not just stereotypy, but there may be something that is a stressful situation that's giving rise to the stereotypy. The stereotypy could be functioning in some sense as a soothing kind of a behavior that a person engages in. We'll talk more about this when we talk about anxiety. Smearing behavior, what does that indicate? This will be talked about probably later on in the other lectures as well. Sleep and or appetite changes. These become extremely important as well. Sleep studies, they may be very difficult to conduct because a person may not be able to keep on the electrodes and the thing that you have to wear on your chest, the communication device that picks up the heart signals and the breathing signals. So a person may have difficulty getting evaluated for something like sleep apnea. But I can tell you, sleep apnea, it's a big deal. And I've seen a lot of patients who had a significant number of problems related to sleep disturbances throughout the night. They got a CPAP, and it was a game changer for some of my patients with a traumatic brain injury. They were able to actually breathe throughout the night, sleep throughout the night, and we all know that science tells us sleep is a very good thing for the human body. Very important, right? It's one of the first areas that we will look at when we're certain to see some problems with a person's behavior. What is their sleep patterns like? The second one is also, what are their appetite changes? Has their appetite changed? Have they lost weight? Have they gained weight? Are foods still appetizing to them? It's one of the questions I ask with depression. Does food still taste good to you? Or does it just taste like you're going through the motions to eat for the sake of the fact that you got to eat? Another thing that we're going to talk about later on is, has a functional ABA assessment been conducted? Because one of the things that we learn about is, as the research comes in, many problems can be solved with a comprehensive support plan. And that support plan is is contributed to by an ABA assessment. It doesn't mean that it's all about ABA. It just means that sometimes we could find out some information through an ABA assessment that will lead us to gather other information that's important in treatment. A lot of this is going to be addressed today in this particular session. I'm briefly going to talk about hallucinations and delusions because we will address psychotic disorders and schizophrenia in one of the later lectures. But in this situation, communication issues that may be related to evaluation via interviews, we got to differentiate whether symptoms are evidence of some sort of hallucination or delusion, or if they are a baseline for developmental delay. Is this person really engaged in a hallucination or delusion, or is it overt self-talk, fantasy, or imaginary play? In general, what we try to do is delusions may be treated and must be treated as delusions, even if they're simplistic or childlike. We caution on the side to say that these things may be delusions until we come to understand the person better, and more importantly, to understand where they're at in their developmental level. When we come to hear a person talking about suicide and homicide ideations, we want to process this seriously. We proceed with evaluating threats, whether they are for functional effect or whether they're genuine. Plans must be investigated. And one of the things that we want to make sure of is that the person does not have access to weapons or any kinds of medications that could be lethal, chemicals, and many other things. Is the environment that the person is going back to after the assessment safe? So we have to realize that the degree of severity in this particular area needs to be taken very seriously. Self-destructive behaviors must be evaluated also within the context of the supportive environment. So one of the things that we want to think about here also is, what are the things that the person's doing? Why are they doing this? What might be the gain that they're trying to do from engaging in this particular behavior? And that's all determined by the context of the supporting environment in which the person is coming from. Medical factors. Again, this is just very broad. Medical problems can be a source of psychiatric symptoms, and we recommend always getting a complete medical evaluation and a baseline assessment. What might some of those things be? One of the things that we might actually do is our doctor may order a full blood count, electrolyte and sodium, liver functions, thyroid functions. These are various areas in which, when we find different kinds of elevations, too high, too low, it could affect behavior. Hyperthyroid situations or hypothyroid situations can produce various changes in a person's presentation. Genetic disorders and syndromes have medical conditions associated with them. Down syndrome, hypothyroidism is oftentimes commonly seen, and it can lead to depression symptoms or early onset of dementia or sleep apnea. Seizure disorders can also be a very important factor in a person's presentation and their diagnosis. One of the things that we always ask in our questioning is questions about, does this person have a history of, number one, seizure disorders? Super important to gather that information. Number two, and one that we always seem to overlook, head injuries. Can you remember a time in which the person fell down the stairs or had a fall or hurt themselves, got hit in the head, got hurt playing a sporting a game, fell out of a tree, fell downstairs? All of those kinds of things become important questions, because there's a lot of times when I've worked with families that will tell me, you know something, come to think of it, and there you go. They get a whole description of my child at an early age. This happened to them. They were sitting up on the counter in the kitchen, and nobody was watching. They took their eye off of them, and they fell bang right onto the kitchen floor head first. Um, and they will say that it left a bump. They were bruised. There was a big area of their head that was injured, but it didn't really show up anything on the scan, or it wasn't serious. I didn't take them to the hospital, or I didn't see blood, so I didn't worry about it. Or my doctor might have said, keep an eye on it. And then when you keep an eye on it, eventually bruises and those things do go away. But these are the things that become very important questions in getting some of that developmental history. Digestive disorders, very, very important. Constipation and impaction. There's a group of doctors that I believe are still practicing up in the Fort Collins area. This is their area of specialization with persons with intellectual disabilities. It's all about digestive systems. They find that a lot of their patients come in and they are engaged in some degree of self-injurious behavior, and there's been some period of time in which they have been impacted and they have not had regular bowel movements. So the other correlate to that is that the families oftentimes may report that after they do have a bowel movement, they seem to be a lot better. So these may be indications, again, of reasons for the self-injurious behaviors, that it may not be randomly directed at parts of the body. There may be perfectly good reasons why they're engaged in that behavior. Finally, urinary infections. Very common. We used to see this a lot of times with some of our patients. Their behavior would start ramping up, and then we would just have them checked out. In addition to what up above, where it was Silka and Hurley, which were describing getting some of those blood counts done and getting that information. Part of that might also be to get a urinary a urine specimen and make sure that there's no urinary infection. Medication side effects may produce akathisia. This is a movement disorder, and that may present as an increase in motor activity that resembles a manic episode or ADHD. Recent medication reductions may be a source of problems. A person may all of a sudden, for example, just stop taking their medications, unbeknownst to the caregiver. They may just be tossing some of their medications, or it may be a deliberate medication reduction performed by the doctor. And where what you're seeing here is just a little bit of residual problem behavior due to the reduction in the medication. It may be that they need the medication, so you might just boost it back up. But one thing we have seen, and we got some beautiful data on this, is that a lot of times when you start making medication reductions, you do start seeing the behavior amp up a little bit, but only a little bit. It's just a reaction that lasted for our patients about 72 hours, give or take a day or two. And then it would just, if you write it out, actually they do pretty good with a medication reduction. So this is one of the reasons why it has to be watched very carefully by the doctor and the team of professionals, that it may be that you're seeing what we call here a reinstatement. It's just a fancy behavioral term that we talk about, which is similar to relapse. Okay. And drug and environment interactions can lead to some degree of relapse as well. There's some data on that. I won't be able to get into a lot of that, but it's fascinating research on how environments could actually trigger problems. Okay. The third thing here is drug interactions and toxicity. It could be that the drug interacts and is toxic with another particular drug, then you should not take those two particular drugs together. That may be a side effect. Increased constipation. That oftentimes happens with opiates and painkillers and Vicodin and things like that. I can recall when I had surgery that they would prescribe for me some of the painkillers. Alongside of that, they would also prescribe laxatives. Colace, I believe, was one of them. That was pretty heavy duty, actually, but it was just a little pill that you take that just keeps things flowing, as they say. Okay. And then finally, altering threshold, seizure threshold. This happened with one of our patients. I'll be talking about him later on in the course, but he was one of the ones that benefited from a drug called Clozaril. It's a very, it's considered one of the best kinds of medications for psychotic behavior, but there's a whole lot of side effects that you have to watch out for. You have to be on a special registry in order to be on this particular drug. The doctor has to be on a registry in order to be able to prescribe Clozaril. But it's a good drug to what we call treatment resistant psychotic behaviors, and very, very effective. With this particular patient, though, it lowered his seizure threshold. So as his behavior got better on Clozaril, he was also having more seizures because the drug was affecting his Clozaril levels. That's what we're talking about here with altering seizure threshold. You could also have visual and hearing abnormalities, which can contribute to the possibility of believing that you're seeing hallucinations or hearing things that are not actually happening. Substance abuse problems, nicotine, caffeine, all of these things contribute to the possibility of problem behaviors, that it could cause excessive movement, it could cause sleep disturbances, and so on. It's important to get the life history when we're working with individuals. I want to point out here some of the things that may be cautionary tales um, when we're gathering some of this information. The first one is that I want to mention that self-report from an individual has limitations. I'm going to spend time talking about that shortly. Um, when a person is giving self-report, we always have to ask the question, how did they come to talk about what they're talking about right now? What was their history that permitted them to be able to articulate the self-report that you're hearing to make your assessment? Secondly, the report from family members, caregivers, and teachers. We have to take in consideration the context of those reports from family members who may be under tremendous stress, and they may be giving you information that is just not accurate. The person is at the end of their ropes, the caregiver, the family member. So they might actually start increasing some of the descriptions so that this person gets services faster, quicker to solve the problem at hand. Secondly, there may be cultural variables that I'll describe later on that keep a family from being able to give accurate self-report. Families just don't talk about that. That's personal stuff. And that may be a variable that limits the ability for you to gather some of this information about life history. I want to point out IEPs and ISPs are generally insufficient. What do I mean by that? Talking about the general ones, the ones that just really are so general that they really don't provide accurate information. They're just kind of, here's the goal, here's the objective, here's how they're doing. That's good information to have, but that doesn't necessarily gather the history of that information. It just kind of gives you a timeline, which begins to put pieces together, but it's oftentimes not enough. I oftentimes will rely on the actual reports of professionals. If there's an OT, I want to know the report from the OT. What's the history? What was your evaluation? What did you see early on? And then, of course, from that point on, all of the markers along the way, the milestones through the IEP. So I kind of need to put them all together and have them juxtaposed as I'm doing a review. I find that IEPs and ISPs just don't do it. They're limited in their number of pages of information that they actually do have. There are other reports that I would recommend. Developmental histories, of course, cognitive histories, communication, academic histories, mental health and psychological reports, medical history, discharge summaries from hospitals. I find those extremely valuable. First and last IEPs if they're an adult. Okay. All right. I'm going to switch gears here and I'm going to talk about treatment models, and one in particular that we're going to focus on, what is called four causes model. Throughout my career, I could recall times in which I would collaborate my practice with the practice of other professionals. This is absolutely necessary to be able to do this. And some of the collaboration was with OT, occupational therapy, speech therapy, physical therapy, recreational therapy. A lot of times my patients who had a traumatic brain injury were in hospitals, so I had to be able to collaborate with nursing staff, social workers, the physiatrist, who is a physical doc, who looks at the physical rehabilitation, um, the psychiatrists and neurologists, even the person's ophthalmologist, if they have a certain brain injury and they have field cuts, and all of a sudden they can't see certain areas, and that will affect their behavior and their mood quite a bit when all of a sudden they're very frustrated from the fact that there's a big field cut and they're blind from seeing things on. They have to only see things from the side. I've got a patient who has this particular problem, and he gets very depressed by his inability to carry on conversations in ways that don't make him stand out by his appearance, by what he's trying to do with his head, in order to be able to see the person in front of them. Why am I bringing this up? Is because it has always been my impression that even though you're collaborating, you oftentimes have an agenda. You listen to what the other people are saying, but you're oftentimes thinking about how you're going to be able to contribute to this conversation, to this treatment model. And you may feel like maybe I should say something. Maybe it's not my place to say something. This is one of the things that I have found over the years, that when people sit down for rounds, they sit down to talk about a patient, whether they're talking about an IEP or an ISP, um, it is an opportunity for complete collaboration, and everybody has a hand in it. Why do I say this? Because number one, there is no one explanation that explains everything. That is, one explanation must be looked at in the context of many other things that are happening in a person's life, in an individual's life. Context really does matter. And secondly, is that I have seen the effect when you have complete collaboration by a team of individuals who have a particular goal of getting this patient treated and getting them back into school, getting them back into the work setting, getting them back into the community, or just getting them back into the good um, favor of the family that they've had problems with, their marriage situation. All of those things become very, very important. And that's where this thing called the four causes comes into play. Let me go ahead and describe to you something that I learned about a couple of years ago and got the opportunity to study with a particular researcher on understanding what the four causes was, why we should think about using it as a model. And I will use this model throughout my talk today, but also on some of the other talks in walking you through why you need an explanation from various different perspectives. So let's start with why a model. I mentioned before at the very onset that there seems to be a risk of early onset of psychiatric disorders, which is influenced by these four areas: genes, environment interactions, developmental history, what particularly happened, in particular if there was a trauma, the history of learning experiences, what were the triggers, what were the things which gave rise to the problem behavior, what gave rise to the traumatic event, what were the consequences of the traumatic event, and then finally, the presence of a specific behavioral phenotype. One of the things that became apparent to me is that if all of these four things are important, they all need to somehow be represented in the treatment and explanation of why a person is engaged in the behaviors that they're engaged in. So I'm going to step back a little bit and walk you through something as an example of the way we kind of perceive the world around us. What am I going to describe here? Well, I want to talk about an event that took place about 3 years ago. It was a Sunday afternoon family brunch that my wife and I attended, and there was some families that were there. There were adults sitting around enjoying cappuccinos and macchiatos. They just got this really brand new espresso machine in their house. And part of the reason why we were having this family gathering on a Sunday was to launch this magnificent coffee machine that they purchased for their home. And we're sitting around sipping our margaritas. No, not our margaritas, our macchiatos and our drinks. And there were also children upstairs playing. It's the children of the families. And they were upstairs because they just had, this was the birthday weekend for one of the kids, Joey. He just had his birthday. And the kids were up there taking a look at his toys and playing with his toys. And all of a sudden, we're sitting around drinking our coffee, and we hear a burst of laughter of the kids upstairs. And all of a sudden, there's this stomping upstairs in the room, in Joey's room. And we heard a bunch of footsteps all of a sudden tear down, running down the stairs, through the living room, and out the front door. And they had, and as they were running out the front door, Joey slammed the door closed behind him. And the force of the door slamming shut resulted in a lamp, an antique lamp that was in the foyer that fell to the ground and broke, this old ceramic heirloom. So that's the scenario. What happened? What did the adults do in this situation? What was the purpose of their conversation? I'm going to describe to you uh, my take on what actually happened and how the adults talked about behavior, because it becomes significant in the process and how we come to understand a model for talking about behavior. So we have mom and dad. Joey's mom and dad are there. Joey's grandparents are there too. Helen and Joseph. Okay, and they were the ones who owned this lamp and handed it down to the parents. The parents, took pride in this and put it on a really nice stand on a table that was located in the foyer. And here's the conversation, how it went down. Mom said, and I'm looking right over here at the left, "I told them not to run in the house." Joey's father said, "Well, Joey led the charge out that front door." The next door neighbor said, "They were bored in here with all that adult talk." And the other neighbor down the street said, "They were all eager to play with that new hoop set you got Joey for Joey's birthday." And then finally, one of the persons said, well, let's not forget they were high from that sugar dessert that you gave them. They were pumped up with sugar. Okay. So there's 5 descriptions of behavior, and they're all focusing on Joey and the children. These are, individual humans, right? And they're behaving, and they're going to give an account here. In this situation, running describes the form of the behavior. I told him not to run in the house. Dad said the trigger was Joey. The next person said they were bored in here with all that adult talk. And that's referring to the state of the system. They were aroused. This is displaced behavior from arousal. And then all of a sudden, one of the persons said, here's the real reason. They were eager to play with that new hoop set you got for Joey. That's the purpose of the behavior, the function of the behavior, the consequences. And then again, somebody comes down and talks about the state of the system, arousal ready for displacement by talking about internally they were high from the sugar and the desserts that they were eating from Joey's birthday cake. Okay, so this is 5 descriptions of behavior from 5 different perspectives. Now, I want to show you something that I thought was quite interesting. At that point, everybody walked over to the foyer and looked at the lamp on the floor, and nobody was talking about behavior anymore of animate people. They were talking about now the inanimate object that was shattered on the floor in the foyer. And look at the way that the conversation went now. Grandma said, well, it's smithereens now. No way even Grandpa could fix it. And then Grandpa, Joseph, said, well, it's not completely their fault, Helen. That old lamp was pretty tippy. A strong wind would have knocked it over. The father, again, emphasized the point that it was Joey who bumped it over. Then it was complaining that was going on. And then Joseph said, Helen, it was missing a 4th leg. That's what he was talking about with the stand that the lamp was on. And then Helen turns around and just barks right back in his face and says, Joseph, I think you loosened that leg just to make this happen because you used to hate that old lamp. You were glad to see it handed down to the family. Okay, now look over on the right side and see that the conversation really did not change. Only the subject of the conversation changed. It's smithereens now. No way Grandpa could fix it. Smithereens describes the current status. It's not their fault, Helen. That old lamp was pretty tippy. Many ways for it to break, but it was the father who pointed out Joey was the trigger for the action. Then Grandpa said, 4th leg was missing. This is describing the state of the system and lacking structural integrity. Not much different than what we were talking about with Joey's state of the system. He was arousal ready for displacement. And then finally, the ultimate purpose behind the breaking of the lamp. The leg was loosened because Joseph hated the lamp. That was the reason, the purpose why the lamp broke in the first place. Okay. It seems like whether we're talking about inanimate objects or animate objects, the source of conversation boils down to 4 particular things. And that's where we come in and talk about the 4 causes of behavior. What exactly are we talking about when we talk about this? This dates back a long way of talking about events in the world around us. How far back? Oh, about 350 BC. Aristotle first talked about the way we talk about and understand knowledge. And when you look at the Greek translations, Aristotle was talking about something called 4 causes, but he was really talking about not the cause of it, but answering the question, why, how, what? And the cause is really because of this, because of that. I was taught to talk about these things by a guy named Peter Colleen, who was a behavior analyst, who has been using this particular model to describe a whole lot of phenomenon that we've struggled with in talking about human behavior. Everything from hypnosis, which is puzzling, to ADHD and what may be going on with ADHD in the four causes sense. But what actually happened was that a lot of this material was lost in the dark ages because people didn't really have access to studying the scriptures that Aristotle produced until it was finally discovered, or I should say rediscovered. And now we find that it serves as a very good model and system for the 21st century sciences. And you will see that it's actually a way for unification of various approaches into understanding a phenomenon. In particular, we use it for neurobehavior. Let me go back one slide and ask you this. Supposing in all the situation that these people are talking about here, every one of them are right. There's nobody who's wrong. Joey was a trigger. You could have had arousal for displacement, and these could be the actual functions. Again, remember that one cause is almost always placed next to a position of other possible causes. The causes actually boil down to what we see here, four particular causes. And that's what I want to kind of go over right now. The first cause that we could talk about is the formal cause. What questions are we asking? And I use the emphasis of the term what. These are what questions. Okay. Models and the way we talk about and represent and describe events. We talk about the essential properties, which make something what it actually is. If we're looking at a sculptor, they may be making a model and studying a model of a statue that will be eventually created. Okay. Now, this essentially means is that we're referring to a particular object or a particular relationship. For example, what's the relationship between three sides of a right-angled triangle? Well, if we remember from geometry, we learned Pythagorean theorem. Oh, that's easy. A squared plus B squared equals C squared. If we ever took a physics course, we might have learned what is relativity. And we answer that question, oh, E equals MC squared. The answer is to the what question is E equals MC squared. That's the formal cause. If a person asks the question, what is depression? You could give a formal definition that we're going to learn in the lecture of what depression is, but that's missing a point. That's only one way of describing what depression is. It depends on who your audience is. If your audience is the funder, Medicaid, and private insurance company, what they're talking about is F32. That's the code. That's what they're talking about. And when we're talking about codes, we have to clarify the what question. When we say, what is depression? And I say, well, it says you're there for 6 months and you're feeling down and you're not sleeping and you're not eating and you're having problems with relationships and cognitively you're not, no, I'm not talking about the clinical cause. I'm talking about the code. Oh, F32. There you go. That's what I'm after. Thank you very much. Same thing holds true with autism. We could describe autism formally, but another formal cause that is clarified is that F84 is the proper code if you're going to get reimbursed. And I want to also point out that one of the things that we learn to do in talking about the world around us, where there is no clarification of science to accurately describe something in terms of E equals MC square, we use metaphors. Here's a metaphor. What is a wise person? Well, according to Ben Franklin, somebody who is early to bed, early to rise makes a man healthy, wealthy, and wise. That is another way of talking about a formal cause. What is a brain? And now we sit down and say, you're asking me what a brain is? Well, it's sort of like a computer or an executive boardroom where decisions are made and processed and boom, output. Here's one for the behavior analysts. What is an increase in behavior after contingent stimulus? The term is reinforcement. Okay. Reinforcement is just a term we use to describe an increase in behavior after a contingent stimulus. We don't take it as a literal cause in and of itself. It's a description. And in fact, it's a metaphor. The metaphor of reinforcement is to strengthen. And the behavior analysts oftentimes talk about something called response strength. That's what reinforcement does. It adds response strength to a particular behavior. And when we reinforce a bridge with concrete to make it stronger, we are also doing the same metaphor to behavior. We're making it stronger, more resistant to change. For example, if we reinforce a bridge, we make it resistant to falling and cracking and possibly falling apart. We do the same thing with behavior when we add reinforcement to behavior, reinforcers. We are strengthening behavior to make it resistant to what? Extinction. That's what. Okay. If you're talking to an occupational therapist and you ask them, what is sensing, organizing, and responding? They'll say, oh, that's what we call sensory integration. Okay. Sensory integration is not in and of itself a cause. In the same way, reinforcement is not a cause. Okay. Because there are other causes that make something a reinforcer or cause stimuli to integrate. We have to take those in consideration. But the starting point that gets us into the ballpark is to have a general description so that we're all talking about the same thing. Okay, that's what we mean by a formal because. Why, what, and how. What is the ability to control muscles used in speech? Answer, dysarthria. It's a term used to describe a relationship. It's not in and of itself a cause. It's the start of getting to understand the cause. But there's more to dysarthria than just the inability to control muscles used in speech. Okay, there's more that goes into that. There's certainly something at the physiological level, at the environmental level, and at the functional purpose of behavior level. Okay, so this is what we call formal causes. It simply is a way to get us into the ballpark of the topic that we're talking about. The second kind of cause is called an efficient cause. I want you to think about efficient causes as triggers. Stimuli and antecedent events that precede behavior. These are questions about why or under what conditions, the triggers that give rise to a particular response, what we call the necessary and sufficient conditions to bring about a change in state, right? And these are the things that we oftentimes, when we talk about causes, this is what we're oftentimes talking about. Events that occur before a change in state. A match caused the fire. Does that make sense, right? A match caused the fire. The match preceded the fire. It was the trigger for the fire. You could also have a situation where necessary causes are invoked to explain failures and outcomes. Why didn't the car start? It needed gas. Hence, gas is the trigger to get cars going. One of the things that we note in looking at triggers is that explanations that rely on efficient causes become overly mechanistic. This was a very big early complaint of early behaviorism. Watsonian behaviorism was one of the ones that were thought to be very mechanistic. Guthrie was another one. Hull was another theorist. These are all early learning theorists that were called and categorized under something called SR theory, stimulus response theory. And a lot of times it looked specifically at what are the triggers, because that's all that's important, the antecedents to the behavior. And what we have come to find out is that that's only partially true. Antecedents are a very, very big part of behavior. In fact, when we start talking about trauma, you're going to be starting to talk about efficient causes in a big sort of way, and things which give rise to depression and anxiety. What are those triggers that are escaped and avoided in those situations? Very important questions, but it's not all there is to understanding. And if all we did was to rely on triggers, our explanations would be incomplete. The causes would not be fully robust because we're missing two other particular causes. Those causes are material causes, the third cause out of the four causes. This is referring to how questions, not why something occurs, not what something is, but how. How does it happen? This is talking about the machinery, substrates, and the underlying mechanisms that commonly occur as causes when triggers are oftentimes inconspicuous. If there's no obvious trigger to behavior, an obvious stimulus, something which everybody could see and say, ah, there's the trigger. That's why that person did that. When we don't see those triggers or they're very inconspicuous, we often rely on these as ultimate causes, but they're really not ultimate causes. These are just causes at another level. Here's an example. When we are going to talk about later on and talk about trauma, and in particular, a phenomenon called learned helplessness, we're going to come to find out that there is a neurological explanation for the phenomenon of learned helplessness and the process by which a person just freezes in the situation and does not have an accurate response. Or they will try to possibly escape and avoid. And what happens when their behaviors do not control environmental events? It turns out, and this is a direct quote from Mayer and Seligman from 2016, passivity and heightened anxiety that we see in these situations, in traumatic situations, are mediated by the serotonergic activity of the dorsal raphe nucleus, the DRN, which actually inhibits escape. That is what we would call a material cause. It's looking at the substrate of the behavior, not looking necessarily at the triggers, but looking instead at the physiological mechanics, the brain science behind it. So this is one type of material cause. A lot of those that I've read over the years in traumatic brain injury, you can't escape and avoid those that easily. They're out there, and a lot of them are very materialistic in their level of causation. We could also use metaphors, and we use some of these metaphors sometimes where we refer to the purpose or the cause of a person's behavior as being something related to physiology. Well, here's an example. When a person quits too early, okay, they quit in an argument, they quit in a discussion, they just really don't do much, and they really don't follow through on things. We may say that they can't do it because they lack the guts. And again, referring to guts being something internal. Or they may say their heart just isn't into it, referring to a person's cardiological system. They're getting on my nerves as a cause of behavior. And what does that mean? If it means that they're literally jumping it down on a person's dendrites, right? They're wired differently. And again, wiring is loosely a metaphor for neurological feedback, neurological activity, axons, nerve cells, those sorts of things. we refer to these things loosely, and we use these things as explanations and causes. When a person says, to me, he was getting on my nerves, so I punched him in the head, I may not really ask the key questions at that point because that person's already answered it. Well, they was on your nerves. Well, if they were on my nerves, I'd probably do it too. But they're not literally on a person's nerves. That doesn't necessarily mean that physiology is not involved. It absolutely is involved. When we get agitated, our sympathetic nervous system switches high gear into the sympathetic nervous system kicks into gear, and we are now in a state, so to speak, where we're more likely to become more provocative in our behavior because the person's getting in our nerves. I want to point out that these explanations, if they're solely based on material causes, these are insufficient because these are what we call reductionistic. These are reductionistic because it reduces down to the level below the observed level of what we actually see a lot of times. Now, that's not necessarily the case with Mayer and Seligman, which is something we're going to talk about later. But in a lot of cases, we use a lot of metaphors, and neuroscience uses a lot of metaphors. Everybody uses metaphors when they're talking, and a lot of them refer to, again, internal world. Okay. That's the third cause. The fourth cause of behavior is called the final cause. Here, what we're looking at here is what has brought about or sustained the phenomenon or process. What are the functions? This is the area that applied behavior analysis works into, doing functional analysis and trying to figure out what might be the underlying purpose behind the behavior. Not all phenomena have final causes, and they may be a breakdown or a failure of systems to serve an important functions of in normal conditions. So we may have a situation where we do a functional analysis in behavior, and we don't come up with a function. How is that possible? Well, it is possible. We have that reported in the literature. We have seen situations where behaviors are not necessarily multiply determined, but you really can't come up with an actual one particular function to pin it down to. It's got multiple functions that are operating here. Okay. And sometimes purpose may be, depending on your range of your scope that you're looking at, the purpose of a particular behavior may be related to something as, on one extreme, genetic fitness. This is why you do this, because humans and other animals that have done this under these conditions live to tell a tale, live to reproduce and add to the gene pool. There's genetic fitness explanations as the ultimate cause versus something that's more immediate in their cause, which is from birth to where they are right now, their history of reinforcement. What has been going on in their life, not in their genes, but at the level of environment. How does genes and environment interact? And then I'd have down here, what about just simply engaging in behavior to do things for the purpose? Why did you do this? I did this to please you. That's the purpose behind my behavior. I have that italicized because that's loosely speaking. When we're trying to talk about pleasing somebody, we're talking about things that probably relate to history of reinforcement and genetics. Okay, why did you do this for me? Because I know from your history of reinforcement, you find this particular thing reinforcing, and I wanted to please you. That's why I did it. Okay. There are two kinds of final causes. The one that we're probably going to encounter, that we mostly encounter as therapists, are proximate final causes. This refers to immediate consequences of some behaviors or misbehaviors. We find that a person immediately, when we see them engage in this behavior in a proximate sense, we sort of understand it. You're afraid of getting on public transportation. You're afraid and you get anxious when you are speaking in front of a bunch of different people, when you're in a crowded room, and therefore you try to escape and avoid those situations. We get that information, and that's what we call proximate. It's what we learn to operate on. So we say, let's see if we could solve this immediate proximate problem. Okay. But what we oftentimes find out, and when we start looking more extensively and working with an individual, there's more to the eye than just what's going on in the proximate situation. We have to think about ultimately what might be going on. There may be a reason why this behavior is being selected. Okay. It may refer to learning histories that a person has long ago that shaped the behavior that you're seeing right now in the proximate frame. Or it may be it's genetic. It's just part of the genetic disposition or influence, which is again referring to evolutionary fitness. That's why they do this behavior. It's you may think of it in terms of I have a fear of dentists. We're going to work on that problem, but there's evolutionary fitness to avoiding things that are painful and noxious to the mouth. So one of the things that you might be fighting here is a person's history of I don't like pain. I don't like needles. I don't like doctors. I don't like nitrous oxide. I don't like any of that stuff, right? That may be their history as well. They may come from a family where the family always used to say, doctors should not be trusted. And now you're going to fight that environmental history with why they're having problems going to a dentist to get a tooth extracted, which they need to do. Okay. So this is again looking at proximate and final causes. Proximate meaning the more immediate. Ultimate is looking at psychosocial history. And the two create a very nice picture of final causes. So let's put it all together, okay? I used to work in a brain injury center in a hospital in which it was an inpatient unit. And we have a situation where I would come in the morning and I would read the report. And the report from overnight said, Bob hit the charge nurse last night. That's what it said. That's the formal cause. This is what gets me and all of these other behaviors going. This gets us into the ballpark. What happened last night? Bob hit the charge nurse last night. That's the event to be explained. Okay. So that's the formal cause, or what we call the formal cause. What happened last night? This is the answer to what happened last night. The next question I ask is, I'm holding the report and I'm going to go directly over to my head nurse on the next shift and say, what was the trigger? What got Bob going that he hit the charge nurse? Now we come to the efficient cause. Well, the charge nurse asked Bob to move his wheelchair away from the doorway. That's the trigger. Okay. Well, is that sufficient in understanding the entire picture? Well, not entirely. Okay. Two other causes have to be taken in consideration. Third, Bob fell from a ladder, sustained an injury to his frontal lobe and temporal lobe, subdural hematoma, which we're going to learn in a couple of lectures from now that's a recipe for some very serious kinds of behavioral outbursts when we have injuries to the frontal lobe dysfunction. That would be the material cause. Physiologically, the brain is not doing what it should be doing under normal circumstances when you are exposed to certain types of social situations. Okay, so again, this may be learned behavior that Bob has learned to do in the immediate scope, but there may be things that are important to understand here too, like the final cause. When Bob strikes the charge nurse, very important, she stops asking Bob requests. In other words, that's the learning history. It's escape and avoidance. Now we have a fairly good explanation based on 4 causes of behavior why Bob did what he actually did, the circumstances behind it, and now we're in a position to do something about it. Let me show you in a schematic how all 4 of these things actually come together. agitation following brain injury. That's Bob. Bob is right in the center where he ought to be. He is the patient. When we ask what are the causes or the triggers of agitation, we're talking about efficient causes. And what was that trigger? Bob's nurse asked Bob to move his wheelchair. That fills in this box. The next thing we have to ask here is what is it about Bob that you ask him a question and he does that? Well, that's where we start looking at material explanations is one thing. That is the substrates. He had a brain injury, frontal lobe injury, temporal lobe injury. This probably affected areas such as the amygdala, and eventually the limbic system's affected by this. And you have now a person who's more prone to aggressive behavior. That's the material cause. The next thing we may want to ask is, what does he get out of it? Why is he doing this? That may be why he does it, but does he gain anything out of this? Yeah, he does. When he goes over and hits the nurse, he's able to escape and avoid the demands, which he just doesn't want to do. Okay. And that's what does the behavior achieve? What's the outcome? That's the functional explanation. Okay. The final cause of behavior. Okay. And then finally, when you put all these three things together, now we could actually answer this question. What did Bob do last night? And we now say, Bob did it. This was the trigger. This was the consequence. And here's the material cause behind his behavior. It's a more complete explanation to explain why Bob's behavior happened the way that it did. Note here that in this system of four causes, it has room for multiple professions, not just psychologists, not just neurologists or nurses, but everybody who's involved in providing treatment, because everybody's answering these same four questions. We have to take a look at the behavioral social systems, but we also have to have an explanation of neural systems. We could oftentimes have this one and this one, but because we have not made certain kinds of progress in getting accurate, direct observation of material causes, there's a lot of metaphor that is oftentimes used and used to be used in brain injury. Not so much anymore. There's a lot of great stuff that's going on in brain injury rehabilitation and brain science that brings us a heck of a lot closer than we've ever been to observing what's going on inside the brain when all of these other things are actually happening. It's quite remarkable. And we're going to talk a little bit more about that when we talk about trauma. All right. We are going to switch gears yet again, and we are going to now talk about functional analysis of behavior. Why are we going to talk about this? This has been the mainstay of a lot of applied behavior analysis work that has been done in diagnosing and treating persons with intellectual disabilities using what's called functional analysis of behavior, and it looks at those final causes of behavior. So I'm going to spend some time talking about what we mean by functional analysis, what we don't mean by functional analysis. Mainly, there's something called functional assessment and functional analysis. What is the difference between the two? Well, the first thing I'm going to do is I'm going to make the case why did we come up with any kind of an assessment for persons with developmental disabilities? In particular, this functional assessment tool, why was it created? What was it meant to do? There is something that we talk about in the behavioral sciences, two types of measurement. One is called vagonotic, okay? The other one is called itemnotic, which is what I'm going to talk about. Itemnotic units of measurement describe standard and absolute units of measurement that we use to describe behavioral action. The existence of these units do not depend on the variability of the object measured, okay? What do I mean by that? Well, what I mean is that when I'm looking at the measurement of time. I'm going to use an absolute standard unit of measurement. The ones that we typically use are hours, minutes, and seconds, right? 24 hours, 60 minutes in an hour, 60 seconds in a minute. These are standard units of measurement. We could use these standard units of measurement to measure just about anything that moves. It doesn't matter whether we're measuring the speed of a rabbit, a bird, a snail, a person who's running, a car that's racing, or a rocket ship. We're still using this nomenclature as a standard unit of measurement, and it's independent of the thing that's actually being measured. The same thing holds true with pounds, grams, ounces, millimeters, inches. It doesn't matter whether we're weighing feathers in pounds or whether we're weighing, or what else could we weigh? Baseballs, right? It doesn't matter whether we're measuring the length of my finger or in millimeters, the length of a scar that I may have actually gotten from surgery. Inches, liters, miles per hour, all of those things are standard units of measurement that we use, okay? For behavior, what might we actually use as standard units of measurement? There are three that we typically use. Okay, one is response count. We just simply count how often did the behavior occur. That's one of the ones that they may actually use when a person's getting a test for sleep apnea. How many times did you wake up in the middle of the night where you weren't breathing? You had 37 wakes per hour. That's a lot of waking up per hour because of sleep apnea. So we can count how many times you woke up that night. If we say how many times you woke up and averaged it by dividing how many hours there were in the night, that's the rate. That's the rate of how many sleep awakenings you had per evening, per hour, or per minute. You could look at the duration of the response. By the way, when your sleep was interrupted, we got an average that you were actually not breathing for about 4.5 seconds. That's the duration of the behavior that we're interested in. What's the latency? The latency is the onset of a behavior given a stimulus. The latency from the time in which the alarm rings, I get up and get out of bed and hit the alarm clock and shut it off. A short latency means that I jumped right up out of bed. A long latency means that I kind of let it ring and ring and ring and ring, and then eventually shut it off. The longer the latency, the lower the amount of behavior that's actually occurring there. Okay, it's that short response or a long response. When we're talking about sleep apnea, it could actually be from the time in which you actually started to go to sleep that you fell asleep and you were in REM. How long, what was the latency before you started to have your first interruption in REM sleep because you stopped breathing? Okay. All right. The DSM-5, by the way, uses these kinds of standard and absolute units of measurement. When you think about it, one or more episodes within a 6-month period, right? One or more episodes 3 weeks after an event occurred, if we're talking about the possibility as a brief episode versus something which is a longer depressive episode, which lasts longer period of time, or it could actually be something that we used to call dysthymia, which is a much longer period of time in which we're seeing symptoms of depression. So they're trying to come up with measures which define this kind of brief psychotic disorder versus another kind of psychotic disorder, which is not brief but more prolonged. We also use it to describe adjustment disorders and treat that differently than we might treat, for example, post-traumatic stress disorder versus another kind of an adjustment disorder. Again, it's related to how long of a period of time have we seen the symptoms. Okay. So itemnotic measurement is very, very useful. It's useful, and the word itemnotic stems from the word identical, identical, which means is that the standard is absolutely identical each time it's used for its specific purpose. So what is a functional assessment, an FBA? It's a method for answering why a particular behavior occurs and keeps occurring. One of the things that we find out is that when you do an FBA, it reduces the chances of using restrictive interventions. And it also is a way for us to allow us to not have these side effects that oftentimes accompany restrictive procedures. We find that an FBA, when conducted properly, can reduce problem behaviors much more successfully. It ends up promoting pro-social behaviors, which I'll be talking about. And more importantly, oftentimes it's recommended and sometimes mandated by insurance companies and others. If you want to do anything that has ABA funding tied to it, you have to probably give them an FBA of one sort or another. What does functional mean? That's an interesting question. I just want to clarify this so that we understand how we're properly using the term. Functional implies lawful manner in which the rate, form, or pattern of repeated behaviors relates to antecedent and consequent historically or currently. In other words, it's the relationship between behavior, antecedent events, and consequent events. That's all it is. It does not imply and should not imply the purpose behind behavior, as the person is doing this in order to do that. What we're saying here is that the two are actually related, because a lot of times there may be a functional relationship and the person may have absolutely no idea whatsoever the purpose behind their behavior, but they are responding to the antecedents and consequences all the same. The data is orderly. We are collecting the data and we're seeing this, but we're not really getting it tied to purpose behind this person's behavior per se. Okay. So a functional assessment represents various processes used to gather information, direct and indirect, about behaviors, environmental, and physiological events. There are three different types that you could do. One is a functional assessment, which is indirect. Okay. And what this involves is self-report, where a person reports what's going on. It involves antecedents, or I should say antidotes. It involves interviewing the person and asking them questions, checklists, rating scales, clinical records, just reviewing clinical records, incident reports, reviewing an IEP or an ISP, and reviewing psychological reports and discharge summaries. That's what I mean by indirect. You're not really setting eyes directly on the patient in question. You're seeing their paper trail. You're gathering information indirectly. That's one kind of functional assessment. The second kind is a descriptive one, in which it's based on observational data. Now you are observing the data, and ABC refers to antecedent for A, behavior for B, and C, the consequent event. What happened before the behavior, what was the behavior, and what happened after the behavior. That's descriptive. The final thing we may actually do is to say we need to move beyond just observing what's actually happening. Let's bring it inside the laboratory, so to speak, or bring it into a clinical setting where we could actually manipulate the antecedents and consequent variables better so that we can learn more about the behavior. A functional assessment attempts to provide accurate descriptions of events and elucidate these interrelationships, these functional relationships. And it ultimately determines the functions of behavior serve so that you can develop really good interventions based on these relationships. Functional behavior assessments have a variety of assumptions attached to them. The first thing is that ongoing behavior depends on the history of success under similar circumstances. What this means is that if you're engaged in a behavior and you continue to do this behavior, you're going to do this because of your history of success. I'm doing this because when I've done this in the past, I've been successful. That's either getting the things that you want in life, doing the things that you want to do, or engaged in escape and avoidance behaviors. Every time I've done this, I've managed to get clear of any kind of problems that upset me. Okay. This is called, for lack of a better term, the law of effect. It's been around a long, long time. Dates back to probably the turn of the 19th century to the 20th century, to the time of Thorndike, who was working with cats in a puzzle box. And he talked about the law of effect, that whenever the cat was in a box and did certain kinds of actions, it was able to get itself out of the box and was there to greet the cat was a plate of fish, tuna fish. And Thorndike used to talk about this effect called the law of effect. That is, when behavior has pleasing consequences, you'll see the behavior occur more frequently under similar circumstances. That's what the law of effect actually is. This is a basic underlying assumption for pretty much the entire behavioral sciences as we talk about it, the law of effect. Behavior that is socially unacceptable can be changed by, first of all, isolating these antecedent and consequent variables, triggering and sustaining responding success, respectively. That is, the antecedents always involve the triggers, but the consequent events are what sustains the behavior over time, not what triggers it, but what sustains it based on the law of effect. Teaching and supporting behavior that competes with unacceptable responses is one of the other assumptions that we make when we're doing functional assessments. That is, we will do an analysis, figure out what the problem behavior is, and then figure out what behavior can they engage in that not only meets their needs, but directly competes with the unacceptable responses. Okay. And then third, avoiding inadvertent reinforcement of unacceptable behavior. Okay. This is something that we try to do to make sure that we're not accidentally reinforcing the very behavior that we want to see decreased in frequency. When we do a functional assessment, we conduct an assessment of biological and physiological influences prior to doing a functional assessment. This is just standard practice. If a person has feeding disorders, for example, and they're coming to us for treatment, we want to do a nutritional analysis, a swallow study, and also assess oral motor skills. We don't just go in and start doing a functional assessment. We want to make sure that it's properly done, that there's not other obvious explanations for this. In other words, before we start looking at efficient causes, the triggers, and before we start looking at final causes, the consequences, we're going to look at the material causes. What are the underlying mechanisms that may be going on, which was recommended again by Anne Hurley and her colleagues. Okay. Here are some functions of behavior, and again, functions in the sense of functional relationships between behavior and consequent events. First of all, we have a category that's called socially mediated. What I mean by that is that when a person engages in behavior, something happens following their behavior, and it's usually produced socially by other persons in the environment. It could be attention-seeking response. It could be social positive type of behavior. In other words, they're engaged in this behavior to receive positive reinforcement. Okay. And it's usually social in the sense of, hey, good job. And it's the social aspect of reinforcement, attention. It could also be material maintained. That is, it's not really a person that's maintaining the behavior, but when a person's doing this, they're getting a thing in return. So a lot of times we see that children will start engaging in challenging behaviors towards their parents to get attention. I want the video game. I want the video game. Um, it's the in a sense they are trying to get their parents' attention, but it's not really their parents' attention that they're trying to get. The parents are a means to an end. It's really it's the social positive reinforcement they're getting from playing a video game. Okay. So that may actually be a material object or what we call tangible. Okay. Material and tangible are one and the same. And then third, escape and avoidance. In other words, it could be every time they engage in this behavior, they escape and avoid social situations that might be aversive to them. This is one of the big things when we're talking about social phobias, social anxiety, generalized anxiety. These folks oftentimes will engage in a variety of different escape and avoidance responses so they don't have to encounter those kinds of environments that they find aversive. Another function of behavior is that the behavior could actually produce reinforcement automatically. That's what we call automatic reinforcement. This produces or regulates sensory stimulation. If I um, adjust my pillow at night, punch it, get it comfortable, I put it down, that's automatic reinforcement. Nobody is coming up to me and saying, hey, Jeff, good job straightening out your pillow. It has nothing to do with anything socially. It's automatic reinforcement. If I scratch an itch, that's automatic reinforcement because nobody's socially coming up and reinforcing me for doing that. Okay. So that's another kind of reinforcer. Another kind that we really won't have time to talk about is something that's contextually induced. These are what we call adjunctive behaviors. And these are excessive behaviors that are induced and maintained by the availability of other important stimuli or events. Some of these behaviors would include cigarette smoking, substance abuse, compulsive behaviors, and domestic violence. These are actually adjunctive behaviors which may not actually have any of these functions that are listed above, but they're induced by other things in the environment that make these things reinforcing. Sometimes smoking is reinforcing, sometimes it's not. Sometimes substance abuse is reinforcing, and sometimes it's not. Okay, and there are reasons why people engage in this particular behavior. And again, we're starting to see that the environment has a lot to do with some of these problems. It's context. Again, we won't have a lot of time to talk about that, but I do want to throw that in there as a possible function of behavior. There are ways in which we talk about functions of behavior. And when we observe a behavior, we oftentimes will break it down to several ways. First of all, when we look at the behavior, we will describe it based on either its topography or its function. What's the difference? The topography is the form of the response. Okay. Self-injurious behavior. The topography might be hitting your forehead with your fist, banging your head against the wall, taking another object and hitting your head with it. It could be um, uh, other ways of self-injurious behavior, pinching yourself, biting your hand, biting your fingers, pulling your hair. All of those things are different forms of self-injurious behavior. Those are topographies. And there are a variety of different topographies for aggression, throwing objects at people, hitting, kicking, biting, um, um, pulling hair. Okay. Those are forms of physical aggression. You could have various forms of property destruction as well, breaking objects, breaking windows, throwing things, Okay, all of those define various typographies. What does the function of those behaviors serve? Well, it could be that a person engages in self-injurious behavior to get attention. And even though you have a variety of typographies of self-injurious behavior of biting your hand, pulling your hair, hitting yourself, banging your head against something, hitting your head with an object, and those sorts of things. Um, all of those have different forms, but they all boil down to the same thing. Whenever the person does any of those behaviors, parents immediately stop what they're doing, put whatever they're doing down. They go over and intervene with the child and say, "Stop, don't do that." That may be the function. And it turns out topographies may have multiple functions. What we try to do is we try to figure out what those various functions may actually be. Hitting others may produce attention, or they may result in escape, or it could actually result in escape and produce attention, multiply determined. Okay, so this is how we sort of break things down in looking at it. The second thing that we break it down in is looking at something called stimulus classes. A stimulus class is when stimuli that happen before a person behaves and stimuli that happens after a person behaves. So a stimulus class is stimuli that vary across physical dimension but produce a common effect on responding. What we're talking about here are the antecedent stimuli. Okay, they are physically different, but they produce a common effect. What might those things be? Well, when it's cold, as a stimulus, cold in a room, what are some of the things that you do? Well, stimuli that may include putting on a coat, putting on a ski cap, putting on muffs, ear muffs, going over to the thermometer and turning up the temperature to make it warmer, like you do in your car when you first get in your car and it's really cold out. You start cranking up the heat in your car. Okay, so you could have all these different stimuli across different dimensions: a thermometer, a jacket, a ski cap, earmuffs, right? All of those kinds of things are different physical stimuli, but they all have the same effect on responding, do they not? It results in essentially the things that you do in order to stay warm. That's what this involves. Stimuli that vary across physical dimensions, but produce a common effect on responding. Okay. And we have this with children. A child may hit siblings, brothers and sisters, all of whom provide attention and are all members of the same class. They're all considered attention givers, but each one is a different physical stimulus, right? Brother, older brother, younger sister, much younger child, younger brother who's a baby, right? If a child hits all of the different siblings, these are all different stimuli, but it's all the same sort of thing. Every time he hits or she hits a sibling, parents come in and give attention to it. Okay, that's the common effect on behavior. Response classes are when we have different topographies that have the same effect on the environment. A child may yell, break objects, and hit, all of which provides escape and are members of the same class. These are all escape and avoidance responses. So even though the person's doing all these behaviors, again, it all boils down to the same thing. Every time they do this, they get the same functional result. Okay? These actually will become very important when we talk about treatment, because if you could find other things that expand the response class. Remember, one of the things you want to conceptualize here is not just this idea of good behavior, bad behavior. Classify it in terms of response classes and note that there are in that response class some behaviors which are dangerous to self and others, which get attention. And what we want to do is expand that, number one, and introduce more ways that are positive to get attention. Raise your hand, say, "Excuse me," say, "Hello, I'm over here. Could you get me this?" So what we're going to do is we're going to expand the response class so that there's more behaviors that a person could engage in to get attention. That's part one. expanding the response class. Part two, which happens simultaneously, is making sure all of the things that are dangerous to the person to get that attention no longer gets reinforced. Extinction. That's the challenge. You're doing two things at the same time. You're going to not respond and then respond over here to the positive behaviors, but not respond to the dangerous behaviors. But we're always thinking about response classes, which actually becomes the way of conceptualizing how we go about doing this. I'm going to show you a couple of tools that we use to do functional assessment. The first one is called the QABF, Questions About Behavior Function. It was designed by Tim Vollmer. I went to, boy, that goes back a ways. I was in grad school with Tim way back when at the University of Florida. And Johnny Matson, who the two of them developed this particular tool, which helps to describe various behavior functions. All right. So the first behavior function that we're going to be talking about here is attention seeking, which is number one. And again, what we're going to do here is we're going to use a Likert scale, which has, if we put a 0 here, it means that no, that never happens. 1, that rarely happens. 2, that sometimes happens. And 3, that oftentimes happens. Okay. And what we're going to do is we're going to assign one of those numbers to each one of these particular possibilities here. So the first one is saying, do they do this behavior to engage in behavior such as self-injurious behavior to get attention? That's what it says for number 1. And we may put there often, 3. The next one, do they engage in this behavior to escape work or learning situations? Is it escape and avoidance behavior? We may put down there saying, rarely, 1. Okay. So we put a 1 right here. The next question, do they engage in self-injurious behavior as a form of self-stimulation? In other words, if we had the child in a room by themselves and nobody was there to interact, would they still be engaging in self-injurious behavior? What might the answer to that be? And we might say never. That could be a 0, right? And then we go to the next question. Do they engage in this behavior because they appear to be in pain? This is asking a question about physiologically, are they groaning, are they grimacing when they're hitting themselves? That they appear to be in some sort of distress. The answer to that may be maybe 1, rarely, okay? And then finally, we come to number 5. Do they engage in this behavior to gain access to items such as preferred toys, food, or beverages? Is this related to a tangible reinforcer? And the person may say, yeah, that's a 2. Sometimes they do gain access to their things that they like because they have a tantrum. And we just give it to them so that they don't, to end the tantrum. So these are 5 questions that address 5 possible functions: attention, escape, auto reinforcement, pain, and tangible. So the next series of questions from 6 to 10 are actually the same types of questions as you ask from 1 to 5. It's just worded differently. What do I mean by that? Well, look at number 6. Do they engage in this behavior because they like to be reprimanded? That's sort of like they like the attention, right? So 6 is very similar to question 1. Question 7, do they engage in this behavior when they're asked to do something like getting dressed, brush their teeth, work, etc.? It sounds like escape and avoidance, which is what number 2 was, engaging in work, engaging in escape behavior to escape work and learning situations. So 2 and 7 are related in the terms of what the function that it's asking for. And as you look down this entire list, you will see that each question is replicated in different words. If we go to question 11, Well, what is question 11? Do they engage in this behavior to draw attention to him or herself? That's another attention question. So they're doing this to look for something that we call internal consistency. That is, if we have a valid tool, then it should come up showing attention depending on how we ask the question, and the attention question should be triggered as similar answers. So if this one gets a 3, number 1, we would expect a 3 on number 6, 11, okay, and so on. 16, in order to get into behavior to get a reaction out of you, attention seeking, right? If it's a 3 up at the number 1, then all of those function questions related to attention should also be 3s too. If you're getting numbers that are all over the map, it means that this is not doing what it's supposed to do. It's not gathering the information. Now, I'm going to go over some caveats to some of these questions that are important to understand when you're using this as an assessment tool. This also comes with this, by the way. This shows you the attention questions are questions 1, 6, 11, 16, 21. The questions on escape are 2, 7, 12, 17, and 22. And all the way down, so you could actually see which group of questions is associated with which function. And what you end up getting is you could graph this, as I've done, oh, sorry about that, as I've done over here, based on how often the behavior is triggered. That is, at least when I ask this question, it's either a 1, 2, or 3. It's never a 0, it's either a 1, 2, or 3. That's how often it is likely to get triggered. But when you start adding up the scores of, yeah, that's a 3, that's a 3, that's a 3, and so on, you're going to get the severity. And it seems to be that with this self-injurious behavior, this particular case, based on data, we see that escape is the biggest leading function to the problem behavior of self-injurious behavior. The next one would be attention seeking. The next one after that might be physical. And then rounding out the end down here is tangible and non-social. Okay. All right. Now there's another tool that we use. I'm not going to go into great detail because it's similar to the one that we just talked about. It's called the FAST, Functional Assessment Screening Tool. And what you're doing here is, once you fill out the information about who the person's informant is, how long have you known the person, how often do you interact with them on a daily basis, how many hours per day, you fill out all this information. It's going to ask you questions in part 1, the first 3 questions on social influence. What are the social behaviors? Is it attention? Is it escape? Is it tangible? It's also going to look at social reinforcers as well, down here with these questions, yes or no. And it also looks at non-social automatic reinforcements, such as the behavior occurs frequently when they're alone or unoccupied. The behavior occurs in relatively high regardless of what's going on in his or her immediate environment. Those are asking questions about auto reinforcement where there is nothing to do with social influence. And then finally, the things that really I like about the FAST, it adds an analysis of precursor information. When the person engages in maladaptive behaviors, such as self-injurious behavior and aggression, they usually vocalize before the occurrence of the response. So when you start to hear a certain kind of vocalization, that's a telltale sign. Yeah, you want to know that kind of stuff, because one of the things that you could do is, if you could intervene on a behavior early at the precursor level, you may be able to minimize further escalation down the road. A lot of research is devoted towards this precursor analysis, and it is very, very effective. Pacing is oftentimes one. A person who paces more and more, eyes going back and forth, rubbing their hands. There may be various kinds of precursor behaviors that a person does before they're about to engage in some sort of more serious kinds of behaviors. The one thing the FAST doesn't do that the QABF does is that this only gives you an answer yes or no. It doesn't give you a severity. And that's one thing that lacks on this particular scale. Okay. And then again, you score it the same sort of way. You add up the numbers, and you would end up with what the function most likely is. So I'm going to kind of go over now what's the difference between functional analysis and functional assessment, an FA versus an FBA. A functional analysis is comprised of a variety. It's not just one thing. It's a variety of different approaches that you could use to ascertain the function of behavior. In the same way that functional assessment isn't just one thing, there are at least 6 different ways that you could actually gather information in a functional assessment, and do that just as easily. So really, what does it boil down to? An FA versus an FBA. Okay. Well, let me describe what a functional analysis actually is. Back in 1982, Brian Iwata, Michael Dorsey, and their colleagues got together and started to do direct observation of children with severe behavioral disorders in very controlled settings. What they would do is they broke down these observations into 15-minute blocks. So first 15 minutes, you observe. Then there's a break. Then you need to observe for another 15 minutes. Break, observe for another 15 minutes. Break, and so on. Okay. And during these observation periods, they called this an analog condition. And in the analog condition, they were able to test the possible functions each separately every 15 minutes. So let's say and these are all randomly done, the different observations that we're doing. So let's say we randomly choose to do giving attention as the first analog to run in this particular arrangement. What we would do is we have a room. It's approximately 7 or 8 feet by 7 or 8 feet. It's just a small classroom, big enough to hold a table and 2 chairs, and maybe some objects that the teacher or the observer can bring into the room with them to use as part of the analog. And in the giving attention condition, what would happen here is that the child with the problem behavior and the person who's in the room with them, the instructor at the time, may sit down at the table, and the instructor is told, do not pay attention to the child when they're engaged in behavior, except if they start engaging in self-injurious behavior, that's when you're going to start paying attention to them. And what we want you to do is, if they start hitting themselves and they start engaging in this behavior, what you're going to do is you're going to go over to them and you're going to say, oh, stop, don't engage, don't do that, stop, please put your hands down. So you're going to give them attention contingent upon this behavior. You're going to do this for about 15 minutes. They start engaging in the behavior, start giving them attention. As soon as they get their hands down and they sit down at the table, you go ahead and sit down as the instructor and continue to ignore them until they start hitting themselves or hurting themselves again. Then you get up out of your chair, give attention. This goes on for 15 minutes. After 15 minutes, there's a break. Okay. And then the next person would come in, the next instructor would come in, and they would run the, let's say, randomly chosen the tangible condition. So this instructor comes in and they've got things in a bag that they bring in with them. Some toys, some fidget toys, some stuffed animals, a ball, a picture book, and there's just interesting objects that could serve as reinforcing to the child. And now you're going to run the same sort of a session for 15 minutes with this new instructor. The old one goes out, new one comes in, and the child is in there. And same thing as before, the instructor is told, do not pay attention to the child except when they start engaging in self-injurious behavior. When they start doing that, I want you to go over to them and open up the bag and say, here, take one of these toys, take a book, give them a tangible or something, which is an object that may serve as a reinforcer to them. They do that for 15 minutes. Then when you give them a book, you sit back down, you would continue to ignore the child until they start engaging in self-injurious behavior again. You get your bag and you say, here, let's get another toy out of here. Okay. That's all the tangible condition is, and that's run for 15 minutes. All right. Then there's a break, and then comes the next 15-minute period, which is the allow escape and avoidance of task. Now you're going to come in with a new instructor. The old instructor leaves. The new instructor comes in with work materials, worksheets, problems, math problems, or it may be things that they have to color or sort, or some sort of an activity that's a work activity. And then you say to the child, let's begin work. And you put the material on the table in front of the child. If the child starts engaging in self-injurious behavior, the instructor's told to remove the work and say, oh, you're not ready to do this yet. And you remove the work that you gave them and put it back into the bag and clear the table of work. You sit back down to the table and wait for them to stop engaging in self-injurious behavior. As soon as they stop engaging in it, you immediately present the work for them and saying, okay, let's begin work. And you try it again and see if they're going to work. If they start hitting again, you remove the work again. Okay, that's the escape and avoidance condition. The final condition is that for 15 minutes after the next break, the child is in the room by themselves for 15 minutes. There's nothing in there. There's no objects. There's nothing in there but a table and chairs. So each condition is run 15 minutes. They alternate and counterbalance orders. Some days you may start off with attention. Some days you'll start off with the alone. Some days with escape and avoidance, but it's all counterbalanced. So it's unpredictable what session, what analog is going to come next because it's all counterbalanced. Okay. Okay. So what the functional analysis does, it describes a process of systematically manipulating behavior and aspects of the environment according to methodologies of experimental design. Environmental events and behaviors are very precisely defined and measured in this process. And this is one of the ways that you attempt to ultimately not just describe, but demonstrate a functional relationship between the behavior and the environmental event. You're making it occur. All right. Okay. At this point, let me point out, is this something new? Is this a big paradigm shift, so to speak, in the way we are analyzing and doing an assessment? And the answer is absolutely no. Setting up analogs where you're going to see possible problems in physiology is the name of the game in medicine a lot of times. When you do a stress test, you're hooked up with all kinds of electrodes. What do they have you do? They have you running on a treadmill. They're getting you to increase your heart rate because even though you note that there may be a risk of increased heart problems, it's one of the ways that they evaluate how well your heart is functioning. And they do this as a stress test. When they do a test like sleep deprived EEGs, okay, what is that? That's when a person has a seizure disorder, but when you have them in their waking moments, they really don't have a whole lot of seizure activity. Where you're going to see more risk is when they are deprived of sleep. And the more deprived of sleep they are, it raises the threshold, or I should say, I'm sorry, it lowers the threshold for seizures if you're sleep deprived. So if you have a person and you instruct them, you're going to come to the lab at night, we're going to hook you up to the machine, we're going to get your EEGs when you're sleep deprived, and we're going to do this and make sure that your EEGs are okay. You're doing the same sort of thing here. There is a risk involved when a person is sleep deprived that they're going to have seizures, but you are doing this to induce seizures so that you could gather information so that you can, in fact, treat it. This is a functional analysis, and it's been done in medicine for a long time. We're just doing it now with behavior. And we've been doing this since about actually before even Iwata and Dorsey did this. We were starting to get the idea that there are probably functions related to behavior and communication. But it was happening probably right around the 1980s, late 70s, early 80s, that this sort of an approach was being used with understanding behavior and assessing behavior. Let me go over some methodological comparisons between the two. On the left, you're going to see the comparison of what a functional assessment is versus the equivalent of a functional analysis. A functional assessment is descriptive. It describes the antecedents, behavior, and consequent events. That's all it is. A functional analysis is much more systematic in its approach. A functional assessment is an indirect approach. It uses records, interviews, tools, versus a functional analysis, which is a direct observation, face-to-face, collecting data. A functional assessment has less control and much less precision in comparison to a functional analysis, which has more control and more precision. A functional assessment is less intrusive in a person's life. A functional analysis is more intrusive into a person's life. There's very little safety risk at all with a functional assessment because these tools do not impose any real risk. However, there may be a moderate safety risk involved when you're having the person be exposed to the very conditions which give rise to the problem behavior, as you do in functional analysis. The functional assessment uses tools and protocols that are well established, whereas the procedures are very well established in functional analysis. The functional assessment requires moderately trained professionals to be able to use this and conduct this to gather the information you need, or a functional analysis requires very highly trained professionals. Going on with the comparisons, a functional assessment organizes information and identifies behaviors and potential antecedents and consequent relationships. That's all a functional assessment does. But a functional analysis is much more precise. It's reliable and it validates data and it validates the environmental relationship. A functional assessment helps develop statements about relationships versus a functional analysis, which demonstrates specific environmental factors involved in the behavior. We use a functional assessment to generate programmatic directions, and it will also tell us which interventions we shouldn't use, okay, such as negatively reinforced behavior. Sometimes if we know a behavior is escape and avoidance behavior, we don't want to contribute to that problem. It's the phenomenon of what we call breakfast in bed. If you know that a child is not going to eat their veggies and not eat the proper food that's put before them at the table, and you say, well, if you're not going to eat your food, go to your room. I don't want you to just sit around the table and sit there and scowl. And the child goes to their room thinking that, this is the greatest thing in the world. Mom and dad think that they're punishing me, but turns out in my room, I've got a bag of Skittles stashed. Mom doesn't know about it. And you go to your room and you start pigging out. All right. That's what we talk about, that if you know behaviors escape and avoidance, you don't want to use timeout as a procedure for escape and avoidance maintained behavior. That would be probably contraindicated. Okay. Functional analysis maximizes the chances of success and generalization, mainly because it's actually getting at the heart of what the real variables are. With advantages, there's also disadvantages of using both of those. I want to go through those with you now. One of the disadvantages of functional assessment is that it relies on an informant who might not provide accurate information. It's not unusual that you get a situation where the informant might be a caregiver, a parent, a sibling, somebody who knows the patient really, really well. But how much do they really know? the other informants? Do they provide accurate information? How long have they known this individual? Have they seen their behavior under a variety of different conditions? Can they accurately report what's important about the individual that's being assessed? That's different than a functional analysis where the disadvantage, it takes several hours to prepare these trials. It's not easy. And when you're trying to prepare something, a procedure, time is money. This is a challenge to limited resources. And there's a lot of times that a functional analysis takes too long, it's too involved, it's too expensive, and therefore it's oftentimes not used because of that reason. Another disadvantage to the functional assessment, the scales restrict the clinician's modification of assessment paradigm. When you have a paradigm and you're asking the question, you got to read the question exactly as it's written. You can't vary. You can't lead the witness, as they say. If you are asking a question on an assessment tool and you know that this informant, they're not getting this question at all, there's very little that you could do about it. You can't really clarify that. You could just say, just try to do the best you can with this question. Because if you start messing around with the wording, you're starting to play around with the validity of the tool itself. On the functional analysis side, professionals conducting trials often don't have direct contact in normal settings. This is really important to think about here. You're in a small classroom, it's 8 feet by 8 feet. You're conducting these analogs, but you've never actually seen the patient in the environment that is the problem, which happens to be the school classroom, not an 8 by 8 foot small room, but a large classroom where there's lots of things there, lots of other students, teachers, paras, a lot more space to move around, and a lot more reaction from other people when you start engaging these behaviors. That's where the functional analysis has some of the problems. It doesn't necessarily lead us to say much about those other settings. Going back to functional assessment, one of the problems, items may be too limited to determine functional relationship. The questions that are asked on the test, on the assessment tool, just may not cut it. They're too limited and it doesn't really get at the heart of the problem. On the functional analysis side, and have I experienced this, older children and higher functioning individuals may catch on to the paradigm. They may catch on to every 15 minutes, the instructor changes and the conditions for reinforcement change. And there's been a lot of times where I've been involved with a functional analysis, and you get through the first 4 or 5 analogs, and then you come back to the attention condition. And hopefully you've randomized the instructor who also comes back in, so that's not predictable. But it doesn't take long for a kid to start realizing and look at you and saying, I know what you're doing. And they're going to be right. They could pick up on the attention component because it is a drastic change going from tangible to escape and avoidance, going from escape and avoidance to attention. These are very big, sudden changes in the environment. And like I said, older kids pick up on that. And once they do, it's game over. You hope that with older kids and higher functioning kids, you could run the FA and get the data as quickly as you possibly can. In the functional assessment, the assessor who's looking at this, who's taking the questionnaire, they may never actually even witness the problem behavior. It's all seen through the eyes of the caregiver or the parent, never setting eyes on the child or the environment in which it occurs. That's a big disadvantage. A big disadvantage to the FA, there's ethical considerations to take into account. It's just more involved. It leads to possibility of injury. And these are things that ethically you have to question, how much is it worth getting this information to actually go through this particular procedure? So when would you conduct a functional analysis? Obviously, you're going to do an FBA first, a functional behavioral assessment before you jump into a functional analysis. When do you make that decision to leap from one assessment tool to the other? Well, first of all, when the functional assessment tool that you use, the QABF or the FAST, fails to reveal consistent behavior environmental functional relationships. Okay, when it fails to reveal some of those relationships. I remember when I used to teach this class to some of my students, and I would teach them how to do a QABF, and they could not wait to get back into their work setting to do the QABF with the problem behavior with this client, with this patient, with this patient, this patient, this patient. They were just, it was like, all right, we've got the tool in our hands. Let's find the function. And I caution them to don't be disappointed if you don't find the function. And after the first 2 weeks that I came back and reassembled the class, they were so dejected. They said, look at this, everything gets this patient going. If you do this, they do it. If you do this, they do it. Multiply determined. It was all over the place. And you got to learn how to administer this and gain experience in getting the questions. Sometimes you will get answers that are all over the map, which basically invalidates the tool. If you are doing a functional assessment, a QABF, and you are doing it with two people who are intimate living together, two parents who know this person, and parent A answers one way, but in a separate discussion with the parent B, they answer in a different way. They're in the same environment, but they see things entirely different. That's going to be a problem because you want to have inter-observer agreement between the people who work well with this individual. That's when you would probably do an FA. When there's multiple determinants of behavior, an FA is probably appropriate. When there's diverse information from an FBA, an FA is appropriate. When no interventions are identified, it may be time to do a functional analysis. When an interventions from your functional assessment failed, and you tried to set it up based on the information on your paper pencil questionnaires, what's next? FA. There are other considerations as well that I want to make sure everybody understands. Risk-benefit analysis. What are the risks involved in doing an FBA? Well, not much, but there may be some risks involved if you delay doing an FA in order to do an FBA first. If you're dealing with some very high magnitude behaviors and it's pretty complex and the situation's complex, you may want to actually think about an FA, a functional analysis, and bypass the FBA because you're going to have to find observers, you're going to have to do a questionnaire, and you may not have the luxury or time to actually do that. And in doing so, you may get some false positives and some false negatives in doing the questionnaire approach. That's risky because time is very important to get treatment into place to do something about it. So there may be a benefit sometimes, not always, but sometimes saying, forget the FBA. That's like taking a temperature on a guy who's having a heart attack. It's just, we need to do much more. We need to do CPR. We need to use a defibrillator. We're not going to do the innocuous little things first. Okay. You also have to take a look at the risk benefit of the functional analysis. If you're doing something on self-injurious behavior aggression, you're inducing the very behavior you want to reduce. Somebody could get hurt. You either get hit in an aggressive way, or self-injurious behavior, somebody may hit the table with their head that you're trying to do the tangible condition, and they hit their head on the table, and now they have a little cut or a bruise or a red mark on their head. Sometimes you have to set up the environment to make it more forgiving. I may put padding on the table to make sure that the person, if they do hit their head on the table's padded. Okay. That might be something I do. I may actually place the table away from a wall so that the person can't just hit their head against the wall to minimize some injury that way. So you have to take a look at the risk benefit analysis. We always point out a person ultimately has a right to effective treatment. This is a person's basic rights that we're going to give them the treatment that is considered the most clinically effective for a person with these kinds of problems. Okay, and again, this is just one thing that we want to consider as we're trying to come up with a proper treatment. We want to make sure that the professionals who are doing the treatment are competent, that they are competently trained. I can tell you, I've done FAs, functional analysis, in the past. I'm not really comfortable doing them. I need to have a certain kind of an environment, and I need to have a certain kind of professional personnel who are also equally trained in doing and conducting the FA properly for safety reasons. Sometimes my setting is just not the place to do that in a learning setting, in a day program setting or a school setting. But the folks over at Children's Hospital in Aurora, Colorado, this is what they do. They're able to do functional analysis. They have the expertise to do it. This is who I send my kids to. Even though I can do it, I'm not going to do it because I'm not comfortable doing it. Not when I have these folks in town who could do it a whole lot better than me. I may, as I mentioned, use protective equipment and protective environment. I always have explicit criteria for terminating the procedures. I don't say, let's run this out a couple of more sessions, do four or five more analogs just to get some data points. You're not going to do that. What you want to do is you want to have explicit criteria saying, I have the data I need. I know the function. We're done. We don't need to do this anymore. The quicker you could terminate an FA with the proper data, the better and the safer. Other considerations, FAs take time. And as I mentioned before, time is money. Cost. Very expensive sometimes. And there's a long wait list to get into the Children's Hospital too for these functional analysis preparations that they do so well. Finally, you got to get informed consent or assent to the procedure is very, very important when you're working with doing some of these assessment tools. All right. That is what I wanted to talk about with functional assessment and functional analysis. Right? Now, what I'd like to do is, first of all, take a sip of coffee. And proceed to limitations to verbal descriptions and the overwhelming problem of privacy. I mentioned to you before that one of the things that influenced me early in my training was the readings of Benjamin Whorf. And in that quote at the very beginning of our discussion today is that language determines how we perceive the world around us. And this is absolutely true about privacy and what we are going to call private events. The ways we have learned to talk about the things going on inside the body, inside the skin, so to speak, is a matter of fact based on the fact that our language is rooted in Judeo-Christian kinds of language approaches. We won't get into the specifics of our language, but I will talk about the problem of our language relative to privacy. It's simply not suited very well for a number of reasons, but I want to kind of walk you through what I'm talking about with some of these limitations. One of the things that we tried to do early on in psychology is to come up with ways that we could talk about the world around us. And one of the approaches that we used was something called truth by agreement. And one of the things that we recognize also in using truth by agreement, that it works for some things and not for other things. For example, what would it work with? Well, the public world, not the world inside the skin, but the world outside the body, exteroceptive stimuli. When we describe the public world like teaching somebody to name a person, name objects, name different types of stimuli and make those fine discriminations, this is possible to do because both the person who's learning it and the supporting verbal community who's teaching it have access to the same stimulus. For example, if you're looking at my picture, this is a coffee cup. It's a physical stimulus, it's outside the body. I could take this coffee cup and use this stimulus as a public stimulus to teach another person to respond to, say, coffee cup. It's how we learn to do this. And what I have here is I have access to this public stimulus. And I could get the person to agree upon this, and I could get other people to agree upon this. And when I do this training, the more people who come up and say, I say, what is this in my hands? And everybody unanimously says, that's a coffee cup, right? That's truth by agreement. And we come to agree upon the fact that we are describing a coffee cup. The way we are able to do that is because both the learner and the teacher have access to the same stimulus. Okay, I want that to sink in. This is really important. All right. Both the instructor and the learner have access to the same physical stimulus. It's in the environment. What about when we're talking about a piano as a stimulus? Okay. What is a piano? And we might ask that in the sense of a formal cause of behavior. What is a piano? A piano is an instrument. We've all seen it. It's got a keyboard that's about, yay big. I play piano. That's about right. Okay. And it's got keys on it. Some keys are black. Some keys are white. They're spaced irregularly, but there's some sequential parts that it's 2 black keys, 3 black keys, 2 black keys, 3 black keys. It seems to be similar down the keyboard. So we could define right down to the, nuts and bolts, or I should say the strings and hammers of a piano to define what a piano is. A piano is not only a visual stimulus. A piano is an auditory stimulus. It has sound. It's a tactile stimulus. It has a feel to it. And you're looking at a picture right now in which we have in the top picture Stevie Wonder, right? And in the bottom picture, Ray Charles, both of whom are blind. If I'm not mistaken, Ray Charles suffered blindness in his early childhood. He did have vision at some point in time, but Stevie Wonder did not. But that's irrelevant in what I'm just describing here. What I'm describing here is that it's not necessarily only a visual stimulus. It's got other properties that make it definable as a piano. And even though these two may not be able to see the keyboard, boy, can they play and compose, and they're masters of this instrument. Okay. When they were learning how to do this, they were able to do this because the fact is it's a physical stimulus. It does not only require visual stimulation, you could execute much of the movements without visual by just having it based on proprioceptive feedback and tactile stimulation of the keys. Let's change things up a little bit. What you're looking at here is a picture from a movie that was out in the 1980s, late 1980s, called Mask. Mask. And it starred these two individuals. And you could see here on the right is Diana. That was the character's name. And on the right side is Rocky, who's got a facial deformity. Diana is completely blind, and she's been blind since birth. She's never seen anything. These two are very, very good friends. Apparently, the grotesqueness of this deformity does not affect Diana because she has no visual input. She does not see what other people see in Rocky and sees him for what he really is. And there's a scene in the movie in which they're out in a field or a grassy area, and Rocky looks up at the sky and sees these beautiful cumulus clouds. And he says, "Whoa, the clouds are beautiful." And Diana asks, "What is a cloud?" And Rocky was had a difficult time defining this because he said, "Well, clouds are they're billowy." And she said, "Billowy?" And the connection was not really made that well. Okay. That's because there is a public stimulus, but only Rocky has access to the public stimulus. The teacher could respond to the public stimulus. The student, who is Diana, cannot. Now, there's a scene later on in the movie in which he tries to teach her more about clouds. If you look up the word billowy in the definition in the dictionary, it says, number one, appearing large and soft or filled with air. That's the definition of billowy. So what Rocky tried to do with Diana is to, later on in the movie, you see him take a wad of cotton over here and puts the wad of cotton in her hand and says, "Here, hold this and squeeze." And she does, and he says, "This is cotton. This is billowy." Okay. And he tried to use this as a public stimulus to teach that which is not a public stimulus to Diana. And unfortunately for Diana and anybody else who is in her situation, she will never understand what a cloud is. Why is that? It's because she's never been exposed to what a cloud is because she can't. It's a visual stimulus, and there's no way to teach a visual stimulus to somebody who is blind when it's only a visual stimulus. If it was truly tactile, if he could fly up into the sky and be in an airplane and have her reach out and touch the cloud and feel it like cotton, now you're talking. But that's just not the case. And because of that, Diana will never truly comprehend what a cloud is and what it isn't. She will never be able to make the distinctions between a cumulus cloud and a cirrus cloud because it is a visual stimulus and only a visual stimulus. What is he going to say? This is feathery and give her feathers versus this is billowy and give her cotton. Those will never be visual. Those are tactile stimuli by their very nature, feathers and cotton balls. So this leads us to talk about public and private events. In describing private events such as feelings, thoughts, emotions, sensations, only a person who is in intimate contact with their own body could ever do this. Nobody else can. This is the nature of privacy. It is our own world, and it is our own world forever. So I'm going to talk to you now about the limitations of being able to teach somebody to describe references to private events. The supporting community, which is basically everybody who's outside in our world, our parents, caregivers, teachers, siblings, friends, neighbors, countrymen, you name it. It's everybody who has the potential to teach us something about verbal things is our supporting community. It changes from throughout our lifetime many, many times. As I mentioned before in Worf's writings, language determines the reality and the way we interpret the world around us. And that changes throughout our lifetime. The supporting community cannot teach the appropriate distinctions of our own body sensations due to something that we call limited accessibility. It's limited in how it has access to the private events. These are important points that I'm going to go over right now. The problem of limited accessibility, it's a language problem. It's not a location problem. What does this mean? The fact is that the private events are taking place presumably inside of the skin, inside of the body. Okay. Our ability to have limited access to this is not a location problem. It actually turns out to be a language problem. The language problem is that we don't have access to shape language when there's not mutual public stimuli present to do so. The boundaries of private events are the limits beyond which the verbal community or the supporting community cannot maintain effective contingencies. You could do it with a piano when you're working with blind people because you could rely on tactile, auditory, and proprioceptive stimuli. You can teach private events based on those things. And we see this quite often, whether we're talking about Jose Feliciano, who played guitar, who was blind, or we're talking again about Stevie Wonder or Ray Charles, who are also blind, but also learned to master their instruments. Okay. They were able to do that because their instruments are much more than a visual stimulus. The boundaries, and this is also a very important point, the boundary between public and private does not give either of these events any special status at all. Just because something is a private event or a private stimulus doesn't make it any more special than it would be if it was a public stimulus. It's not mental, it's not non-physical, but when we have these private events, and this is the crux of the argument here, they are our responses to our own physiology. That's what a private event is. It's how we respond to our own internal world of physiology. Neurological activity, brain activity, structural activity, tactile activity, all of those things are private events. And it's our response to our own physiology, not mental and not non-physical. They're real. They're very real things that are going on inside of our body. They're not mental events. I want to point out two things that become a gap and become a problem when we're trying to conceptualize this, because I'm asking you to make a leap for a second and consider the possibility that Worf is right in what he said. Our language is will determine our reality and how we learn to talk about it. If there are gaps in the way we conceptualize our reality, then we need to kind of figure out a way in which, is it a language problem? Which is what Worf is saying. It's a language problem. And here are two traps that I would like to kind of point out to you. Private events, by their very nature, will precede public behavior almost 90 to 95% of the time. Okay. In other words, it is much easier for me to think about raising my coffee cup right now and engage in the private behavior of thinking about it as opposed to doing it, picking up my coffee cup and taking a sip. It's easier to execute public behavior sometimes versus private behavior, but that's rare. That's oftentimes rare. I only think about the times in which, if I'm driving a car and I all of a sudden see that there's a cop on the side of the road before it's too late, when they're just sitting there hiding behind some bushes, I could easily very quickly engage in public behavior of hitting my cruise control, turning it off, and slowing down so I could avoid and escape getting a ticket. And then moments after I engage in that behavior, which is public, then the private behaviors start. Whew, that was close. Whew, I could have gotten a ticket. Wow, that was really careless of me to be going 85 miles an hour in a 75-mile-an-hour zone. All of those cognitive thoughts could come after the public behavior of me um, taking care of my speed at that moment in time to avoid the ticket. But more often than not, we will make the case here that private behavior precedes public behavior most of the time. And because of this sequential thing, private, public, this makes us easy for us to mistake the private as causing the public. All we could say is that private behavior precedes public behavior. It's not a cause of behavior in and of itself. It's all part of the same behavior. From a behavioral perspective, so to speak, thinking about raising a cup of coffee and drinking and engaging in it, it's all part of the same behavior. You're looking at different topographies, but it's all the same function. So the two traps that we could talk about here is number one, billiard ball causality, big trap. Billiard ball causality works like this. If I hit the cue ball hits the 2 ball, which hits the 5 ball, which hits the 7 ball, and eventually the 7 ball goes into the side pocket if I'm playing pool. If I look at that, that's billiard ball causality. Cue ball hits the 2, which hits the 5, which hits the 7. It's a sequence. One hits the other, which hits the other, which hits the other. Stimulus response. As I mentioned before, the idea here is that stimulus response is an efficient cause, but it is only one kind. It's reductionistic to think that everything works in billiard ball causality. And it actually doesn't work in billiard ball causality because when you look at behavior, behavior could be maintained by consequent events which come after everything and will come to determine how that preceding antecedent works. Okay, so how we learn to discriminate is very much in keeping with this idea that billiard ball causality is not the way of the universe. There could be instances where things do not follow billiard ball causality, such as contingencies of reinforcement do not follow billiard ball causality in that sense. The reinforcer is the final event, not the initial event, which gets the chain going. Okay. And it's that reinforcer that's going to determine possibly whether all preceding stimuli the next time will even have an effect at all. Okay. The causality really is in the final causes of behavior, the purpose or function of behavior in these instances. The second thing I'm going to talk about is a trap called the temporal gap. When we see behavior happen and we see time, a temporal gap, and then we see another behavior happen. Here's a stimulus, here's a response, and a whole lot of time passes between that. It could be seconds, it could be minutes, it could be hours, it could be weeks that we're talking about a gap between the evoking stimulus and the actual response. A lot of times what we end up doing is we try to fill that temporal gap. We fill it with cognitive accounts. Because the idea here is that we can't handle this idea of behavior and a stimulus that's separated in time. We have to fill it with things that actually take place that might be going on, processing, encoding, and all kinds of other cognitive terms that are used to fill this temporal gap when we actually have no evidence of that, number one. But more importantly, number two, we have learned that events could happen across a temporal gap. And I'm not just talking about behavior, I'm talking about physical events. There's something that we could call spontaneous supersaturation. What does supersaturation happen? I saw this in high school, and I thought this was a pretty impressive experiment that my teacher did in chemistry. He took water and he boiled it. And he boiled it to the point of bubbles, and he would put salt in there and dissolve the salt so that you could not see the salt in the water. It took a while to do this, but he did this as a process over and over again. He'd add more salt and keep boiling, add more salt, keep boiling. He got it to the point of supersaturation. And with supersaturation, um, you cannot see the salt. It just looks like clear water. But if you are very careful and let the water cool and don't disturb it, don't flick it, don't bump it, don't do anything, and let it just stay there, it'll sit there and it'll look absolutely clear until all of a sudden, at some point in time, you all of a sudden start seeing the salt fall magically in down to the bottom, and then you see the salt collecting at the very bottom spontaneously. Nothing jarred it, nothing happened, but this was an event that was across a temporal gap. It took some time to do this, but across the temporal gap, this actually happens. And it wasn't necessarily because the water cooled. It seemed to just be, again, a reaction, a chemical reaction that happens across a temporal gap. And these are instances that happen in physics, and there's no reason to assume that the physical world is any different for humans than it would be for other substances or other animals. These are two traps that I want to kind of leave you with here, because in our world, we try to use billiard ball causality as the way the whole world works. And by doing that, we start thinking about private causing public behavior, and that might not be the case at all. And number two, we start filling a temporal gap with cognitive structures like memory and those sorts of things to explain behavior across a temporal gap, when in fact, we don't necessarily need those kinds of constructs to explain behavior that can occur across a temporal gap anymore. Well, given the limitations that we have in teaching private events and being able to talk about private events, we seem to do it. We seem to be able to have found a way to provide this kind of training to individuals so that we're not in trouble. And there are three ways that were pointed out by Skinner in 1945 in a paper called The Operation Analysis of Psychological Terms. It's a classic paper. And he describes these three different ways that we use to teach verbal behavior about private events. The first one is called the public accompaniment. When we're engaged and feeling, quote unquote, feeling private events, okay, there's oftentimes some public manifestations of that private event. If I talk about the term nausea, one of the things that accompanies nausea is vomiting, which is clearly observable, sweating, which is observable, and temperature change, which can be detected by an independent source such as a thermometer. Those three things are public accompaniments to the private sensation that we say nausea. And we will oftentimes use those three behaviors in sum to shape up a person's response to teach them what nausea is. If we are working, if we're a parent and we see our child, vomiting in the toilet, we see them sweating on their forehead and their face, and we feel their forehead, and we could do like my mother used to do all the time, put your hand to their forehead and tell whether they have a temperature or not. We would use those three public accompaniments to teach the child to say, oh dear, this is called nausea. You feel nauseous. This is what the feeling that you're going on right now inside of your body is called nausea. The second thing that we may use is something called a collateral response. In this situation, these are not publicly available stimuli like vomiting, sweating, and temperature, which can be easily seen. And again, truth by agreement. Two or more people could observe somebody vomiting and saying, yeah, he's definitely got nausea. But with a collateral response, what you're doing here is there's no public accompanying stimuli, but you are engaged in behavior that is in direct response to the private event. If I've got a stomach ailment, I've got stomach cramps, I've got nausea, I may start groaning. Oh my gosh. Oh, I may start holding my stomach. Those are collateral responses. They're not public accompaniments. They're not something that naturally happens as a direct result of the nausea, but these are learned responses that a person does, grimacing, groaning, holding the stomach, which would be possible indicators that something's going on. If I come into a room and I'm holding my stomach and I'm groaning, the first reaction out of my verbal community, who might be my wife, might say, you see, I knew you shouldn't have eaten all of that food. Now look at you, right? Um, the problem here is that it's not absolutely positively certain that I'm having a stomach ache. I could be faking it. I could walk around groaning, holding my stomach because I really don't feel like going outside in the yard and picking up dog poop. So I kind of say, I'm not feeling well. I'm going to go lie down for a little while. Okay. There's secondary gain to be done by doing that of the collateral responses. Now, does that happen all the time? Absolutely not. But I could tell you, when I was a kid, my mother knew the difference. She knew my collateral responses when I didn't want to go to school. And she immediately, rather than relying on my moaning and groaning and saying, Mom, I'm not feeling well, she would immediately break out, or I should say, bust out the public accompaniments. Let's take your temperature. Let's let your thermometer do the talking here. Okay. Um, she would always put her hand on my forehead. And if that didn't work, she would take her face and put her face up against my forehead. This was her looking for public accompaniments. All right. Okay. So that's the second way that we teach people to talk about. The third way is through extended metaphors. The metaphors that we use to describe private events are all based on things that we observe publicly. All right. For example, if I say a person is throwing up in quotes, that is referring to the metaphor of vomiting. We observe it, we could say, oh, yeah, they're throwing up. And that's one of the terms that we use to define. And again, one of the things that we learned early on in studying language is that many of the words that we use for cognitive terms are not really cognitive terms at all. They were borrowed by observation of public behavior. If I say I'm inclined to do something, I'm inclined to agree with you, I'm inclined to go to the movies with you, I'm inclined to go to bed in about another hour. Inclination, and I'm inclined to do that, is a type of cognitive term. But think about this. When we are inclined, what is an incline? It's going like this. It's leaning, right? To say I'm inclined to go to bed in an hour is sort of like saying I'm leaning towards going to bed in an hour. It's a term that we use that's borrowed, a cognitive term that's used based on an observation, right? There are lots and lots of examples of that. Let's talk about headaches. What kinds of headaches can we talk about? Can we make finer distinctions? Yeah, we could talk about a pounding headache. A pounding headache we've all experienced perhaps, and it's a pounding headache is that when I close my eyes and I have this headache, I feel my head going like this. Pound, bang, 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 right? If I have a tension headache, certainly that's different than a pounding headache. We sort of know this. How did we come to talk about that? That is also a term that's borrowed by external stimuli. When I take I take a rubber band and stretch it out and I make tension. Yeah, that's what my head feels like. It feels like my brain is like a rubber band that's being stretched. Again, it's a term that we use that's a metaphor for the private event. if we think about lots of things such as love, um, we talk about the heart, right? That's the part of the body that love starts taking place. That's why on Valentine's Day, you get a heart filled with candy. It's a metaphor because when we feel like we're in love, it feels like there's sort of some sort of stimulation that's happening, oh, just beneath the sternum. And when we are brokenhearted, it feels like somebody ripped our heart out, right? These are the terms that we use. And when we have pains, we describe pains, like I said, tension pains. Here's some that we describe excruciating pain. What's the term excruciating come from? It comes from the root word of crucifixion, which is painful event. So again, we use these terms, and the very terms that we use to define cognitive events inside the body are all seemingly based upon our observations of how we feel when we're exposed to these different conditions. We oftentimes talk about sex being like explosions and bottle rockets and things like that. And we use that expression sometimes to describe when I look at bottle rockets and I see explosions in the sky and I feel exhilarated when I see the next one go off. That's a metaphor. And it was used in many movies and television programs. There used to be a program on in the 70s. Boy, am I dating myself. But anyway, it's called Love American Style. And Love American Style was hearts on the theme, on the music. And it always showed bottle rockets going off in the sky, indicating that that was symbolic of love and the exuberance that one feels when one is attracted to another person. So, in these three ways, we are able to shape up verbal behavior with people about private events, knowing that even though we're doing this, there are limitations to us being able to actually communicate those private events. There have been clinical applications that we've used over the years. Um, One, relaxation training. I'll be talking about this when we talk about anxiety. This was one of the first things that I learned how to do when I started clinical practice. I had the opportunity to know and work briefly with Joe Catella, who is a behavior therapist in the Boston area. Great guy, very good friend. Um, and he was really big into two things: relaxation training. He published a book with June Groden called Relaxation Training for Persons with Developmental Disabilities. Great book. I still use it. And he also used something called guided imagery, which he really did a nice work with in terms of teaching a young girl to, for example, control her seizures and how to eliminate falling down when she had a seizure and be able to uh, withstand having seizures versus just collapsing on the spot. Um, they've used these applications in teaching private events for childbirthing. The Lamaze method is very much related to some of this private public information. When a person, when the woman who is in labor is dilated, we oftentimes will use certain kinds of metaphors. We have them engage in alternative behaviors like breathing, doing their breathing, cleansing breathing exercises. And this is some of the training I remember I had to do with my kids with learning Lamaze method many years ago. Covert conditioning, again, referring back to some of the work that Joe Catella did. ACT is very much based on this distinction of public-private distinction. Biofeedback, and again, I'll talk about that when I talk about anxiety in our next upcoming lecture. And there's even been a functional analysis of psychotic speech and thought disorders. An attempt was made to use certain kinds of approaches in behavior analysis to understand the origin of psychotic speech. Interesting work that was done by Joe Ling and Paul Andronis. Great, great work. All right. What I'd like to do is walk you through this notion of being able to talk about self-report, being able to talk about private events. How are we able to do this? What is the limits to being able to talk about this? And what are the limits to introspection in general? This has been a topic that we've talked about for decades. What is introspection? Where does it come from? How accurate is it? Are we to really take it literally when a person says these certain things about their private events? So let me walk you through a little bit of scenario here. If we're talking about consciousness and we're talking about being conscious of something, what we're talking about is the ability to talk about it. Consciousness is a social product. Being able to talk about anything, we are able to do that because of our verbal community. They teach us to talk about the things around us, and they have rules around how they talk. Again, quoting Worf, language will determine the reality of the way we interpret the world around us. So if I have a person, let's say, for example, I am with a friend of mine. We're walking through Washington Park here in Colorado, and we're eating some food. We have a wrapper, and we're eating some sort of a burrito or a taco or something like that. And I finish, my friend finishes, we're still walking. I wad up my paper and that my taco was in, and I throw it into the garbage can. My friend's not finished yet. He continues walking and he's eating and eating. Eventually, we continue walking. He finishes his taco. He wads up the piece of paper and throws it on the ground, littering. All right. What am I going to do about that situation? Well, I'm going to want to use this as a learning opportunity. I want to teach him and raise his consciousness, as we used to say a lot in the 60s and 70s, raising somebody's consciousness, which essentially meant three things. And that's what I want to kind of talk to you about. If I'm going to raise somebody's consciousness, I should see three things, at least three things happen in response to my training that would be an indicator. Have I done the trick? Is this person's consciousness really raised at all? And there's three things you have to be able to do. Number one, to be conscious of something is to be able to talk about it. I go over to my friend, I say, what are you doing? You just threw it on the ground. Didn't you see what I did? I waited and I threw it into the garbage can because that's what you do in the park. You littered, you left this on the ground, and now look around you. There's nothing on the ground except your litter. And I said that that's just one of the rules socially that you don't do. And you don't do that in Washington Park. This is a beautiful place, and they have to pay people to come around here and pick up the trash that you leave there. Okay. So I am able to talk to this person, my friend, about this. And most importantly, he should now respond in kind to say, I never thought about it that way before. That is littering, and that is really a bad thing to do. I agree with you. He picks up the paper. Okay. Then we walk back over to the garbage can, which is just a couple of meters away. He throws it into the garbage can. Have I raised his consciousness? And the question is answered by us, maybe. Because two other things should also happen. The next time he puts something in his hand and we're walking through a park or a similar sort of place and he finishes with it, on future instances, is his behavior changed? Does he seek out a garbage can and throw it out? So he could talk about it and say that it's a bad thing to do. He can now, on his own, find a garbage can and respond with respect to it and do what he's supposed to do. That's two of the three. Have we raised his consciousness? Well, what happens if my friend is walking in the same park, eating the same type of tacos with another friend of his. And they're walking through the park, and he himself takes his garbage and throws it in the garbage can. But they continue walking, and the friend that he's with takes a wad of paper and throws it on the ground, and then they just continue to walk. What do you say about consciousness then? You start questioning it, because the third thing that represents consciousness is that you should be able to transmit the rules about the contingencies. And you should be able to say, hey, what are you doing throwing that down there? I learned just the other day you shouldn't do that. You shouldn't do it either. Pick that up and let's throw it away the way we should. When you see all three of those behaviors, you're in a much more comfortable position to say that they are really conscious of the contingency of littering and why you shouldn't do it. Hopefully everybody understands that. It's not just one thing, it's usually three things that we're looking for here. It's the demonstration of a change in performance. The second thing, and this is really important, is that to be able to talk about something, you must be taught by your verbal community, your supporting community. That's the nature of consciousness. There's a great book that was written by Julian Jaynes called The Origin of Consciousness and the Breakdown of the Bicameral Mind. Big, thick book that I had to read in graduate school. But in that book, Jaynes describes in great detail the nature of consciousness, what it is and what it's not. He does that beautifully within the first opening pages that captivates you, that once you start reading his writing, he just grabs you. He's a great writer. And he's one of the ones that really promoted this idea that most behavior analysts do, that behavior and private events, to be able to talk about it, you have to be taught. It's a social product. And in turn, as I mentioned to you before, the supporting community that does the teaching has to have contact with that same stimulus as you, making it a public stimulus, sort of like it was for Mask with the cotton and the clouds. That didn't work, okay? But with a piano, it works with people who are blind because there are multiple stimuli that make up and comprise the definition of what a piano is and is not. You need to make the stimulus public. Colors, rough sandpaper, salty tasting things, sweet tasting things, a ringing bell, okay? Those are the things that the verbal community has access to. This is super important. The verbal community has contact with only the evoking stimulus. They never have contact with the sensation that you're getting. They see you looking at a piece of paper and saying red, and they see a red piece of paper, they have access to that same color. They see you take your hand and rub your hand across sandpaper and go, oh, that's rough. That feels rough. Or you could see them rub their hands across their face um, after they shave and they say, oh, that's smooth, right? You only have access to the hand rubbing the face. You don't have access to the smoothness that the person is experiencing, nor the salty taste that they taste, or the sweet taste, or the bell that is ringing. I have tinnitus. I've had it for years. And nobody has access to those stimuli except me because it's of the nature that I can't really um, access it, or nobody else could access it. But I use metaphors to describe it. It sounds like a bell ringing. You know what it really sounds like? It sounds like about a million crickets in my head, and my head is in a tunnel, and all I hear are crickets all the time, which is why I wear these crazy hearing aids, because it actually eliminates those other sounds so that I don't hear those crickets. And it enables me to hear conferences, go to conferences and hear talks, which I couldn't do before. Okay. So the verbal community has contact with the evoking stimulus. Never do they have contact with the sensation. This is called isomorphism. One-to-one correspondence with the stimulus. I see you touch the rough sandpaper. I could touch the rough sandpaper. I see what you're touching. That's the evoking stimulus. And now I could shape up the response, feeling rough paper. This is sandpaper. It feels rough. Okay. The thing felt inside the body are physiological behaviors. It's not feelings per se, but things that are felt. When you have a feeling, what is felt is the central nervous system and the autonomic nervous system. Okay. And these are real things. These are real physiological events. We can measure these events to a large extent, better than we were able to do actually before. Even 10 years ago, the things that we could do into detecting various types of activities, ANS activities and CNS activities, has drastically changed, and it will continue to change, proving once again that it's not a thing called a feeling, but it's an actual physical event that's going on inside the body called a thing that is felt. These are private stimuli, and it's not because they're located inside the body. It's because the supporting community never has contact with them. There is no isomorphism. There is no one-to-one correspondence. It's private stimuli, and it will always be private stimuli, and there's nothing much you could do about that. Therefore, the supporting community cannot adequately teach accurately verbal behavior about private events. That is, the supporting community cannot teach us to talk about a private event like they can teach us to talk about a public event. And I want to point out also, this is not a technical problem. It's not like we're going to all of a sudden go into the brain, invade the physiological system, start measuring MRIs and functional MRIs and PET scans, because that is not the private behavior. All those things are public accompaniments of the private event. An MRI is not the private event. A PET scan is not the private event. When you see these programs on television and they see the brain lighting up and a part of the brain lighting up, that's not the private event. All that is that's a public accompaniment that is occurring at the same time as the private event. The two are not the same, right? All right. That's all I really wanted to say about introspection. Again, one of the points that I really want to emphasize here is that when we're dealing with self-report, regardless of functioning level, which we need to know and recognize, over and above that, there is a problem with self-report. There is a problem with introspection, even in the so-called neurotypical population. We have a problem with it. We try to get around it through those three methods that Skinner talked about in his paper. But by and large, private events will always be private. It is our own private world, and that's all there is to it. We have not evolved the proper limbs and systems to detect private events in a manner that's going to go beyond anything that we have right now. Can't happen. Okay. But I do want to talk about the evidence-informed treatments that we do have evidence for, that we can respond to, and use certain kinds of behavioral techniques in order to teach people to respond to private events, but also how to actually move forward in terms of treatment. I want to talk briefly about, again, do we address behavioral topographies or address function? Topographies are oftentimes addressed by looking at the form of the response and changing the form. When I work with a lot of occupational therapists, they work a lot on topography. They work on the form of the response. Are you gripping it right? Do you have the right fine motor movement? Do you have the proper gross motor movement? PT also works on topographies too. How are your gait? What's the distance of your gait? They may look at your range of motion using a goniometer. Again, these are ways that they may address data or address problems, but you could also address function. That is, sometimes, regardless of topography, you could look at the function of behavior and teach a different function, teach that a different behavior, different topography for the same function. That's what we're going to talk about here in a second when we talk about some of the replacement behavior training. Evidence-informed treatments oftentimes will inform which procedures to avoid or which ones are contraindicated. As I mentioned to you before, with negative reinforced behavior, escape and avoidance behavior, you really don't want to use timeout procedures because those are contraindicated. You do want to take advantage of competing events, though. Replacement behavior training, it's also called RBT training, replacement behavior training. I prefer competing behavior training as the terminology than the replacement behavior training. But in the terms, if you see the two, they are usually synonymous. And what you're doing here is you are taking a look at the analysis of what the function of the behavior is going on, what the function serves, as we say. And we are going to say from now on, that behavior, we're not going to reinforce it. We're going to find other behaviors that you could do that will accomplish the same means, the same end of getting the reinforcers that are important to you. In other words, there was a quote that was used by Horner, Bob Horner, and it was this: you make the problem behaviors irrelevant, ineffective, and inefficient. That's what replacement behavior training essentially does. You make it so that there's other ways to get their needs met so that they don't have to do these other behaviors that are problematic. They're irrelevant. They don't work anymore. They're ineffective. They're inefficient. There's easier ways to get your things that you want, such as attention and tangibles. We oftentimes want to use errorless teaching or fading techniques. These again are techniques that have been developed to enhance the learning process. We'll be learning about some of those when we get to the section on anxiety and we talk about prompting hierarchies. Okay, errorless learning and errorless fading. We want to modulate response requirements, how much they have to do and how accurate they have to do and the duration that they have to do. One of the things we'll be talking about in future trainings is something that we call shaping and fading. Sometimes what we'll already do is rather than making a challenging task over and over again, so every time it's a challenge, sometimes we'll introduce a master task. So it's a little bit easier so the person could, do something hard, do something else that's hard, then do something that's really easy. Make a task very, very easy. Okay. Finally, we want to modify antecedents and motivation. We'll learn how to do this in future classes. Again, this is the prompting hierarchy and the peer modeling methods that we'll be using to teach and instruct how to respond and how to deliver cues in learning situations. We won't have time to get into many motivational operations, but this is something else that we address in behavior analysis too. It's the idea that you could change the value of reinforcers for a person to make something more valuable to them than just what they're getting out of doing it right now. Treatments that are contraindicated based on function. Here's some of them. Attention maintained behavior. If you see a person engaged in problematic behaviors that's attention maintained, avoid delivering verbal reprimands and getting on their case about it. Avoid interrupting them. Avoid redirecting them. Again, they're doing all these behaviors to get your attention, and those three interventions actually feed into attention maintained behavior. Behavior that is material maintained, objects, right? Tangible objects. When they engage in this behavior, make sure that you deny them access to those items. This is one of the biggest ones that I work with on a day-to-day basis with kids, teenagers, with video games. Much of their behavior is all about the video games at the exclusion of family life, school, and other important activities. And in a situation like that, a person is escaping and avoiding everything just so that they can gain access to their video games, their Roblox games, and all the other ones, Fortnite, right? They should not have direct access to these things when they're engaged in problematic behavior. And they should not gain new toys and throw tantrums so that they could get more things online. Third, automatic sensory maintained behaviors, avoid withholding attention or timeout. avoid withholding attention or timeout, because they're not doing it for social engagement. They're not doing it to escape and avoid. They're doing it because they're doing it, and you need to intervene. You don't have the luxury of using a timeout procedure. It will continue to go on even in the absence of timeout. Escape and avoidance maintained behavior. Avoid timeout, as I mentioned before, and or avoid withholding attention. Okay. A couple of things that we're going to also mention here, just for sake of completeness. We want to modify the consequences that a person is getting for their behavior. We want to provide reinforcement for low rates or durations of problem behaviors. That's if you don't engage in this behavior for the next hour to 2 hours, we lower the rate and the duration of the problem behavior. We can provide reinforcement for the absence of behavior. It's what we call DRO, differential reinforcement for the omission of a response. We could provide reinforcement for acceptable behaviors instead. Make sure that the frequency of reinforcement is good, the duration of reinforcement is good, and the reinforcer onset is immediate. Okay, this is very important to make replacement behavior training effective. It follows the rules of something that we won't talk about, something called matching law in behavioral economics. Okay, it's something that we recognize that reinforcer values change over time and circumstances. And what is a reinforcer today with a person may not be a reinforcer next week. So I learned very quickly from my daughter growing up. I thought I was always trying to be hip and know all who the big names were in the rock world of her rock world at that point in time. So I knew all about Spice Girls and Aaron Carter and Backstreet Boys and all of those kinds of bands, and wanted to make sure I knew that, because if I'm starting to think that she likes some of that music, and I go out and buy CDs or something for her, for a reinforcer, those reinforcer values change over time. I present her with Spice Girls and she says, "Oh, Dad, Spice Girls are just so yesterday," because the values change over time. Okay. All right. I'm going to stop there. And that brings us to an end. This has been a long, long lecture, but this is the longest one of the series. I wanted to make sure that you understood everything that you needed to know about the problems with assessment, the problems with introspection, the problems with self-report, and the problems in general when you're trying to do an assessment with persons with intellectual disabilities, and there is a communication problem. That's significant. It's going to interfere with many of the tools that are used that we have at our disposal that we would typically use for persons without intellectual disabilities. So, given that, we're going to go through at least 6 different kinds of disorders over the series of lectures in which we're going to talk about these same issues coming up, but how do we get around it? How do we nail down, is this depression? And if it is depression, what are some of the most effective means of treatment that are available based on evidence? Well, thank you very much for your time. I appreciate it. And I'm sure I will see you around in later lectures. Bye-bye.